everyone, online and in person, for we calculated the 10th Coli Institute Imaging Summit. It seems that every few years this summit changes. It actually began in Cleveland as the Peter Kaiser OCT meeting, and then we realized no one else would come to Cleveland, so we decided to bring it to ASRS. I think at one point we named it Octoper for some sort of random reason, and now it's the Coli Institute Imaging Summit. So the 10th year of this, and welcome everybody. We've had to adjust. Last year was virtual only. This year we're going to do a hybrid program, so thank you all who are here and those who are joining us online. It should be a great program. We have a lot of wonderful speakers. And let me just run through a couple of things on our slides, which will hopefully forward. Try now. Still not. It's nice to be back in a real meeting where slides don't work. I'm not getting yelled at by the peanut gallery, though. This is great. I'm so excited. I mean, this is wonderful. All right, here we go. The faculty includes our hosts from Cleveland, including Peter Kaiser, Justice Ehlers, myself, Rishi Singh, and Kat Talcott. We have a fantastic faculty of visitors, including Glenn Jaffe, Jaya Kumar, Ted Lang, and David Saraf. All these people, of course, need no introduction, some leaders in our field, and we thank you all for joining us. We have our activity sponsorship by AKH and iVista. We have our learning objectives up. I'm not going to read them for anybody here. But I want to thank our sponsors who have graciously supported this meeting, and many of these sponsors have continued to support this meeting for several years: Alcon, Apellis, iPoint, Heidelberg, Iveric, Optos, and Regeneron. Thank you again for supporting our meeting and continuing to do so. For those who are here in San Antonio, we have something called an exhibitor passport. So for those who are here, you have a little passport. In the breaks, if you go over and visit our exhibitors and you get it stamped, at the end of the meeting, we're going to have a drawing for some wireless Bose headphones for those who get it filled out, and we're actually giving 2 of these away. I've been told Rishi has already claimed one of them, so there's one at least that's available, and Saraf might get his hands on it before anybody else. If you do have questions or comments, if you're joining us online, please use the comment box below the play screen. And we are going to get to questions and comments from everybody in our panel discussions. We have these actually set up just to talk about some of the questions that are coming from online. And for those who are here, we'll have a microphone and a stand for everyone to talk with. So with that, we're going to get started in just a few minutes. I do want to remind everyone to please at the conclusion of the program, you'll have an email with instructions to do a post-test, and that's how you'll be able to get your CME credits. Well, it's my pleasure to start this meeting and to introduce Rishi Singh. Rishi needs no introduction. Rishi's at the Coli Institute Cleveland Clinic. Rishi's going to talk to us about the quantified fluid analysis in the real world versus clinical trials. Rishi.
It's really kind of you to leave these headphones right next to me so I can just walk off the stage. Thank you, Sunil, for that parting gift. So I'm going to summarize some of the data we've learned from studies about quantifying fluid. Here are my financial disclosures for the presentation. So we treat neovascular AMD by looking at various characteristics in the patient. We look at visual acuity, we look at hemorrhage, we look at the presence of fluid or the absence of fluid. We look at central subfield change, and there's a condition that we're looking at more often now with CST variability, sort of the amplitude of the increases and decreases in retinal thickness. PED height morphological changes. We use those to kind of manage our patients as well. But we currently don't quantify retinal fluid in clinical practice right now. So why should we? Well, multiple studies have shown that these compartments have some value, that intraretinal fluid has a negative prognosticator in many of these trials I'm going to show you through the data sets that we've discussed, and that CST does not always correlate with fluid in AMD, and I'll show you why that is in a few different studies in the next couple slides. We know that fluid volumes now can be actually precisely identified, localized, and measured using artificial intelligence and deep learning algorithms, and the presence of fluid has functional impact beyond vision. And some of the sub-studies as I've been involved in the past couple of years have really examined NEI VFQ-25 scales and their relationship to fluid volume and status within those patients over time. We're used to these non-quantitative assessments, and I'm going to run you through some of these studies that have been non-quantitative in value. The CAT trial was one example of a non-quantitative assessment, found that IRF had a negative prognosticator, and SRF had potentially a positive prognostication with regards to fluid outcome. This, again, does not mean you treat and don't treat patients based upon these fluid volumes. This means that these are biomarkers for their positive and negative visual outcomes in these patients. The VIEW trial found very similar results with aflibercept versus ranibizumab, again showing you negative prognostication with intraretinal fluid, potentially positive prognostication with subretinal fluid. And in fact, it showed even patients who had not a dry retina at 3 months after treatment had a negative visual outcome as a result of not having a dry retina within 3 months. So we now have the basis for which we can say, obviously this fluid, especially intraretinal fluid, has a negative prognostication, especially early in disease. Another trial that, again, looked at non-quantitative values now has a quantitative paper out, which I'm going to summarize in a moment, but basically found this a non-quantitative study that those with SRF alone had the best visual outcomes. Those with resolved SRF and IRF had the next outcome measure. Residual subretinal fluid had a negative prognostication. Finally, IRF alone had the most negative prognostication with regards to visual acuity within the Harbor study. Again, a PRN treatment for these patients over time. And finally, we had the fluid study, which looked at gross amounts of fluid, actually took in a prospective fashion and said, let's not treat patients with fluid that's present. 200 microns essentially was that amount, which essentially is the retinal thickness in this case, and looked to see what the visual outcomes were and found very similar visual acuity outcomes at the end of the study. So this was just the only look at a prospective trial that actually managed fluid in an active fashion, again, non-quantitative in this way, but found some value at doing that. Well, we have some validation recently in some artificial intelligence platforms, and this is actually one of those platforms that's been evaluated. It really showed in this paper that these AI platforms can actually compare well with retina specialists. So in this case, it took 3 retina specialists, graded the fluid amongst them, and found very high sensitivity and specificity approaching 92 and 94% in the fluid volumes that were analyzed through this AI platform. This was the NOAA platform from Notal Vision that was tested within this study. Again, there have been multiple different other position papers on this because obviously there's many different ways to quantify fluid. So this paper actually by Usha Chakravarty, Tieran Kiernan, Anat Lowenstein, Emily Chu, and Ursula Schmidt-Erfurt really found that there was no consistency in the measurements of fluid. How would you call that volume there? And what they proposed in this position paper actually they were going to use this nanoliter as a convenient volume unit. And so therefore we use nanoliters, and I will show you those in the next quantitative slides I'm going to show you where nanoliters are the way we're going to be quantifying this going forward in the studies that were done. This was a nice study using the National Eye Institute data set, which actually processed, again, some images with a deep learning algorithm. And what they found in this was actually quite interesting. We're using an investigator, which is in the dark blue, versus the NOAA platform, really had good accuracy and specificity. But when it came to sensitivity, the investigator did much poorly than the NOAA platform. This is where it really matters, right? This is a place where if you have, fluid in this patient, you want to be able to pick it up to treat it. And this is, again, showing you where the value of this platform may have some advantages over what we do in today's practice, which we look at the clinical volumes, look at the retinal thickness, and say, I think you can continue to go on the same treatment regimen you've been on altogether. One of the other important findings from a lot of these artificial intelligence pathways is that we don't see the entire perspective of what's happening with the patient when we look at the single line scan. And what this slide shows you is on the baseline amount of fluid within the patient, both within the fovea, the 3 millimeter and the 6 millimeter volume scan, and in the baseline subretinal fluid measurements. And first and foremost, you see a vast amount of fluid is present outside the 3 millimeter scan. So that's important to, I think, recognize as a baseline factor. And in fact, when you look at the treatment profile after a single injection of an anti-VEGF, which had a nice anatomical response, there is a lot of fluid still outside that central region. So you might wonder, again, whether this activity is being measured appropriately across the board if we are missing fluid outside of the central fovea in these patients. This slide really shows you what I think is the one takeaway slide from my entire presentation, which is really looking at the correlation between what we do all the time, central subfield thickness. Where is the patient's thickness from where they were before, and the correlation with intraretinal fluid. And what it shows you essentially is that the R values are 0.59 and 0.49 in these patients, which shows you very, very poor correlation with the fluid levels within these patients. And here's again SRF just showing you the same value. The R value here is even worse, 0.24 and 0.40, which again shows you very little correlation with the quantitative value and CST. So what studies have quantified fluid thus far? The ones in red have had qualitative measurements. The ones in yellow have actually had quantitative measurements. Actually, I'll tell you about the Harbor trial, which just released their data with Mark Zarbin as the author of that paper. So there is some quantitative data in that, but the paper just was released quite recently, and I don't have that as part of my slide deck, but I'll reference that later in the talk. Hawk and Harrier actually had a quantitative value, and what you found essentially in this study with Beovu, in this case brolucizumab, was that brolucizumab did a great job of essentially having this equivalent effect with regards to IRF drying in comparison to aflibercept in the study. But when you look at the actual effect of brolucizumab, actually was on SRF. And that was, again, contraindicated or contradictory what we've learned so far. I've been telling you all along, these quantitative studies have said that SRF is actually a positive prognosticator. So what's the value of Beovu if it necessarily dries SRF? Well, this is just the reason why this quantitative assessment is so important. Because when you actually look at this in a quantitative way, and this is Ursula's work she's done, and this is the low disease activity and the high disease activity looked at by SRF, IRF, and PED status, you find that all of the fluid levels were essentially negative prognosticators to visual outcome. So it's not so simplistic to say that SRF has a positive prognosticator. I think the issue is we never quantified it as such through these AI platforms. We looked at it qualitatively, and unfortunately, I think we missed the boat on a lot of the SRF. IRF, we know already, was a negative prognosticator of visual outcome, so it did confirm the qualitative measurements that were performed. This is a really busy slide, but what it shows you on the far right side is that if you look at IRF and PED and SRF with their low activity scales, they had a really good visual outcome. The y-axis in this case is the visual outcome here. But look at the far left side. If you had IRF, PEDs, and SRF at the highest level of disease activity assessed in the Hawk and Harrier trials by this AI platform, you had a hugely negative prognostication with regards to visual acuity. So again, showing you the validation that this really matters. But what about the real world? Ejection frequency is far different. There's no adherence to treatment regimen. Some of us treat and extend. Some of us do PRN. Sometimes we have patients that are monthly therapy because we can't get them dry. And switching between drugs on the effect of fluid outcomes may have an effect. And we do it a lot in clinical practice, that they're not done in clinical studies. So this was actually Ursula's paper that looked at this in her UK EMR database. And what she found essentially was what we thought about all along. Again, using the NOAA AI platform in this case, she found that SRF and IRF were negative prognosticators to visual outcome. And in fact, PED size was also a negative prognosticator as well in this study. We've actually completed our study at the Cleveland Clinic. This is awaiting publication right now of 286 patients we used with the NOAA platform. We use a 6 by 6 millimeter cube to analyze these B scans in our patients. We found initially that there, again, was that potentially positive prognostication with regards to SRF, but you actually look at the quantitative values in here, and here again you showed that linear mixed regression analysis. The IRF definitely had the negative prognostication, but the SRF had no negative prognostication. So why the difference between our real-world study and the one I showed you by Ursula and others? Well, I think that there's definitely differences in injection frequency between US and UK studies. Those are done by nurses, and we do it by people like Sunil. And there's differences in their injection habits. They give loading doses if they get a fluid component that appears. They put them on 3 loading doses, and they start off on loading doses from the beginning. And again, their injection numbers are far greater than what we do in our clinical practice here in the United States. So that might be why we didn't see the differences there as well. But I think I hopefully have showed you through this presentation that disease activity is not served simply by CST change over time, that fluid subtypes, when quantified, have baseline outcome differences. And I think it's important that we remember that these are not biomarkers we're using to drive our treatment decisions. These are just biomarkers that appeared as we treated the patient. And I think that studies like the fluid study and maybe studies in the future with prospective trials that are going to enroll patients with an AI platform may help us better identify how we should manage these patients actively with these disease states and these various compartments of fluid over time. Thank you very much for your attention.
I think we're going to do questions at the panel.
Sure.
That's all right. If that's all right. We're going to keep going here. And our next speaker is David Saraf. David's going to talk to us about, is subretinal fluid protective? Pathways of fluid leakage in AMD.
So this is actually a great segue from Rishi's talk, and we'll delve into the mechanisms of fluid leakage as opposed to quantitative measurements that Rishi was getting into, and we'll talk about subretinal fluid It may not, I agree with Rishi, it's certainly not protective. It may not even correlate with good visual acuity, but I don't think it's as negative a prognostic correlation as intraretinal fluid. And so we'll get into all of these items as is summarized in this slide, discussing the different pathways of intraretinal and subretinal fluid, neovascular and non-neovascular pathways, and then we'll get into talking about subretinal fluid, why it persists, and why is there this correlation with good visual acuity. So we understand from medical school that there are really two major pathways of leakage, exudative and transudative pathways. And exudative pathways are associated with disruption in the, do I have a pointer here? Oh yes, go back. Disruption in the cell membrane, whereas the transudative pathways are associated with fluid leakage when the cell membrane is intact. Intraretinal and subretinal fluid, similarly, in the context of macular disease, can have different pathways of leakage, and these include neovascular and non-neovascular pathways. Let's talk about the neovascular pathways. Typically, we associate intraretinal and subretinal fluid as tried and true essential markers of neovascular activity, along with sub-RP fluid and SHREM. And this usually is an indicator of an abnormal vascular endothelium, in this case associated with the neovascular membrane. Here you can see intraretinal fluid, subretinal fluid, sub-RPE fluid. That's all the result of this type 3 RAP lesion that resolves along with the PED after anti-VEGF therapy. In this lesion, in this patient, there is subretinal fluid, sub-RP fluid due to a type 1 neovascular membrane. You can see similarly resolution of the PED and the neovascular lesion on the OCT after Eylea injection. Here's a patient, no fluid, no intraretinal or subretinal fluid, only the presence of SHREM, an associated neovascular lesion on OCT angiography. This was deemed a sign. The SHREM was deemed a sign of neovascular activity. The patient was treated. The SHREM resolved and the vision commensurately improved to 20/25, indicating that the SHREM was indeed a sign of activity related to the neovascular pathway. But it is important to understand that fluid, both intraretinal and subretinal fluid, can be the result of other pathways, not just exudative neovascular pathways. And these include degenerative mechanisms. Many years ago, Solomon Cohen in France described these pseudocysts, which can occur over areas of geographic atrophy. You can often see these when drusen or large drusen or druzenoid PEDs collapse, as in this time-lapse video. You see the development of RPE atrophy, C-RORA, which is an OCT classification, and the development of that pseudocyst there, which is a degenerative pathway of leakage. Here's another example. And finally here, this large Druzanoid PED, signs of RPE disruption, those hyperreflective foci. The Druzanoid PED collapses, RPE atrophy and C-RORA develops, as I said, a correlate of GA, and then you can see all these characteristic cysts, which are not a sign of exudative or neovascular activity. They're a sign of a degenerative pathway leading to fluid leakage that may perhaps be related to Mueller cell loss, which have been implicated as a very important mediator in hydrostatic control of fluid in the retina. How about subretinal fluid? Can we see subretinal fluid in non-neovascular pathways? Yes, we studied this, and in this cohort of patients, we identified all these patterns of fluid at the apex, as a drape over confluent drusen, or even at the angle in patients with just non-neovascular intermediate AMD. And this fluid was associated with signs of RPE disruption. Many of these patients went on to RPE atrophy. And here's some more examples of patients with large druzenoid PED and apex of fluid, and then the eventual development of C-RORA and GA on the fundus autofluorescence. And another example showing subretinal fluid in a patient with non-neovascular AMD, a non-exudative pathway. In this patient who was referred to me, the patient was referred for injection. She had already received several anti-VEGF injections, but I was unable to see any evidence of neovascularization on the OCTA, either with segmentation of the outer retina or the choriocapillaris, so I decided to monitor the patient, and the fluid didn't change. The fluid actually improved because it was the result of a non-neovascular pathway. Why does this happen? Well, we believe that it may be related to RPE pump failure in this particular context. The larger the drus or the Druzanoid Ped, the greater the separation from the underlying choriocapillaris, which supplies and supports and nourishes the RPE, and then the RPE pump begins to fail, and you get fluid at the apex, which is furthest away from the choriocapillaris. And then that can lead subsequently to RPE breakdown and further failure as the RPE degenerates and progresses towards death. So let's talk about persistent subretinal fluid in patients with neovascular AMD. I believe this can be the result of both neovascular and non-neovascular pathways. Here's a patient who has type 1 neovascularization, subretinal fluid. After injection, you can even see maturation of the neovascular lesion. There's improvement of the PED, the SHREM, and the subretinal fluid, but there's persistence. Persistence is a real phenomenon that has been quoted to occur in about 25 to 50% of patients with neovascular AMD. Why does it occur? Well, certainly there's an active exudative component, and this has been shown in the CAT study, which showed that the monthly ranibizumab arm had the lowest incidence of persistent fluid, indicating that active exudation is a factor in persistent fluid. Similarly, in the Hawk and Harrier studies, the aflibercept arm had the greatest amount of persistent fluid. Brolucizumab, which is presumably a stronger anti-VEGF agent, was associated with less persistent fluid. So this indicates that there is an active exudative component to persistent fluid. And here in this case example, you can see persistent subretinal fluid after aflibercept. Brolucizumab starts and the fluid resolves. But there may be other factors involved, and we can get some information about this looking into this correlation again of subretinal and intraretinal fluid. Subretinal fluid has again been correlated, and specifically foveal subretinal fluid, with better visual acuity, or at least not with negative visual acuity. And intraretinal fluid has been correlated with poor visual acuity in the CAT study that Rishi also highlighted. Rishi also mentioned this study in which we analyzed the Harbor database, and we showed again that subretinal fluid was associated with greater increments of visual acuity improvement, whereas intraretinal fluid was associated with less increments of visual acuity improvement. Why is that? Why are we seeing that correlation with intraretinal fluid? Well, with intraretinal fluid, I think it's obvious why. I've explained to you one possible explanation is that these cysts often occur over areas of geographic atrophy or C-RORA, and this may be driving some of the negative correlation that we're seeing with CME. With subretinal fluid, the explanation's a little bit more tricky. With subretinal fluid, as I showed you in the non-neovascular cases, there's often fluid above an RPE that's still functioning but is impaired. And I think when we're seeing fluid in these cases, it may indicate that the RPE is still functional and still viable, although impaired and not functioning at an optimal level. And that indicator is also borne out by the fact that eventually the RPE will die in some of these patients. But when there's subretinal fluid present, it may indicate that it's still functional and viable, and perhaps that may be a sign of more viable activity and more viable photoreceptor survival. I think this is also another factor to consider is the neovascular lesion. Here's a patient with persistent subretinal fluid. There's an active neovascular lesion. It's growing on OCTA, and that may also be driving fluid and overwhelming the RPE. Why is the vision still good? Well, because the neovascular lesion is still active, and it may be sustaining and nourishing the overlying RPE and recapitulating the choriocapillaris. So an active neovascular lesion may actually be a paradoxical benefit to vision and visual acuity, especially when the RPE still has a viability and functional benefit. Look in this case, on the other hand, in which the neovascular lesion is what we refer to as hypermature and associated with severe atrophy. At this point, we see collapse, there's thinning, the RPE is completely atrophic, and fluid washes through to the choroid. And so in these cases, you expect to see poor visual acuity outcomes. So in summary, Fluid can complicate both the neovascular and non-neovascular components of AMD. Intraretinal and subretinal fluid are essential markers of exudative neovascular activity, but they can also be an association they can also develop in degenerative pathways. Persistent fluid may be the result of both neovascular and non-neovascular factors and may indicate that there is a viable RPE that is still functioning but impaired, as well as a viable neovascular complex that's nourishing and sustaining the overlying RPE. Thanks for your attention.
David, thanks for that talk. It was fantastic, and we're slowly killing Glenn Jaffe on stage. We'll talk more at the panel discussion about the presence of fluid. It's my pleasure to welcome, you haven't broken your ankle yet,
Not yet.
one of my mentors from Duke, Glenn Jaffe. Glenn's going to do 2 lectures in a row. He's first going to talk to us about multimodal GA assessment in clinic and clinical trials. Glenn.
Thanks very much, Sunil, and I very much appreciate the opportunity to speak and appreciate Justice and your invitation. We're going to switch gears a little bit and talk about atrophy, and we do a lot of multimodal assessment in the clinic and also at the reading center. And by way of disclosure, these are my consulting activities. And the key take-home messages are that I do believe that multimodal assessment is helpful in geographic atrophy. Atrophy is seen in both non-neovascular and neovascular AMD, and macular atrophy is an approved primary endpoint for geographic atrophy studies. But we need to make sure that the criteria that we use are reproducible, and I'm going to show you that I believe that the criteria that we've been working on with the classification of atrophy group are valid. So why is this important in the first place? Well, atrophy, presence or absence, is used to determine eligibility in a variety of types of macular degeneration trials, neovascular and non-neovascular, and the incidence and progression is followed during the course of these studies. The initial characteristics, whether it's multifocal or whether it involves a fovea, may determine the progression rates. There are a lot of different ways that you can image atrophy, and they're often complementary. Each of them has their strengths and weaknesses. And in the first publication from the CAM group, this is the Classification of Atrophy Meeting Group, we described the protocols that are used for assessing macular degeneration and with a focus on macular atrophy. The key modalities include fundus autofluorescence, near-infrared imaging, fundus photography, fluorescein angiography, and optical coherence tomography. Fundus autofluorescence, as you see here, depends on the incident wavelength, and blue light autofluorescence will give you this spot in the center, hypoautofluorescent spot, whereas if you use a different wavelength, for example, if you use near-infrared imaging, you don't see that spot, which is because of the absorption by the xanthophyll pigment, or the luteal pigment. Pathologically, hypoautofluorescence corresponds to absent or dead retinal pigment epithelium, but if the RPE are compromised but still there, they may be hyperautofluorescent, or if they're piled up on one another. So this just shows an example of the hypoautofluorescence from the missing RPE with the surrounding rim of hyperautofluorescent with the dysfunctional RPE. We use near-infrared reflectance imaging to help with our assessments, and I think it's very useful for, as I'll show you, to evaluate the autofluorescence. You see a circumscribed area of atrophy. Sometimes you have a dark border which defines it very well. But in this case, you see the autofluorescent image and the near-infrared next to it. Sometimes it's hard to tell whether this dark spot in the center is the normal hypoautofluorescence or pathological. And you can tell in this case, you actually see the atrophy on the near-infrared reflectance image. We use fundus photography and fluorescein angiography as well, and Druzin to determine whether there's AMD. Depigmented round or oval areas with well-defined boundaries is the hallmark on color fundus photography, an older way to measure atrophy, but also is useful to see signs of macular neovascularization, which may be associated. And this slide may be a little bit dark, but you can see that there is a circumscribed area of depigmentation, and in this case, it's surrounded by the Druzin to define the non-neovascular AMD. Fluorescein angiography is also very helpful, and you can see the well-defined area, circumscribed area of hyperfluorescence surrounded by the pinpoint areas corresponding to the Druzin. And this is useful not only to define the margins when you're trying to assess when you're trying to quantify, but also to pick up drusen, and especially to look for absence or presence of macular neovascularization that may accompany the atrophy. And here you see the fluorescein angiogram with the well-circumscribed area of hyperfluorescence, and this is surrounded by punctate areas. This was the starry sky appearance of cuticular drusen. OCT really is the key imaging modality to assess atrophy, and it's the primary one to determine whether atrophy is present. We use it for a variety of purposes, to look for loss of retinal layers and RPE and choroidal hypertransmission, as David just showed you. We look for border abnormalities with OCT. We look for drusen, which can define the presence or absence of macular degeneration, and we can also measure the choroidal thickness. It's especially helpful for measuring the proximity to the foveal center. Does it involve the foveal center or not? OCT is the right way to use to determine that. I've been throwing around the term atrophy and geographic atrophy, or macular atrophy, geographic atrophy. I want to tighten up the definition a little bit. Macular atrophy is the general term and can occur in either neovascular or non-neovascular AMD. CRORA, or complete RPE and outer retinal atrophy, is the OCT correlate, the OCT term for defining atrophy. Geographic atrophy, by consensus, we use the term specifically to refer to non-neovascular AMD. So if I'm saying geographic atrophy, I'm talking about non-neovascular AMD. This is from our consensus CAM group, the report 3, where CRORA was defined, complete RPE and outer retinal atrophy. What does that mean? It means that there is loss of the outer retina, and you see a subsidence or a sinking down of the internuclear layer and the outer plexiform layer. And that's combined with loss of the retinal pigment epithelium, 250 microns or more, and that goes along with choroidal hypertransmission. The signal can penetrate into the choroid because of the loss of the retinal pigment epithelium. So that's CRORA. We were interested at the Reading Center, at the Duke Reading Center, to see whether we could apply this definition in real-life clinical trials. And we wanted to see how reproducible these measurements were. And so we used OCT to identify the atrophy, and then we measured the atrophy on fundus autofluorescence using those additional modalities. Well, that's what we do. Is that a good thing to do? So the first question was, could we do this reproducibly at the Reading Center? But more practically and importantly, could we apply that in clinical trials to differentiate treatment group from control groups? And we looked at this in a couple of large trials for which we served as a reading center. So we use dual reader grading. 2 readers grade it. If there's a discrepancy, a third person arbitrated, but we're particularly interested in the primary readers' reproducibility. We did this in a large neovascular AMD trial, and I'll show you some data from that trial. We also did it in a phase 3 geographic atrophy trial, which I'll also show you. And we used that CRORA definition for determining atrophy. So we looked at gradability. How well could the reader determine whether you could even assess the parameter accurately? And so we looked at a variety of parameters. Was the atrophy present? Was it in the center millimeter? Did it go into the foveal center? How many spots were there? What was the lesion area, which is a critical aspect? And then we also looked at those parameters and said, if we could grade it, how good were the readers at reproducibly assessing that parameter? So we looked at gradability and the specific parameters, and we used the different modalities to do the assessment. And I'm not going to show you the detailed analysis. I just want to give you sort of a high-level idea of what we found. 93% of the time, the readers agreed that we could grade the presence or absence of atrophy. And this is in the this is in the neovascular AMD trial, and it's actually inherently more difficult to grade atrophy in a neovascular AMD trial. The gradability on atrophy area, how well could you define the area of atrophy? 87% agreement. Now, this is, I think, a beautiful fundus autofluorescence image. It has very good contrast. The blood vessels are black, the optic nerve's black. You see the very dark hypoautofluorescence with well-circumscribed boundaries. The readers are going to 100% of the time agree that that one's gradable. You might be surprised, but we get a lot of images that look like this from clinical trials, and this actually came from a GA trial. Are you going to be able to grade that? This would be 100% non-gradable, and there's poor contrast, poor resolution. Think to yourself whether you can outline the area of that lesion. Now, what about this one? This is a really nice quality image. You see the hypoautofluorescent spots. How well are you going to be able to outline those spots? I'd say this is borderline, and this gave rise to some of the discrepancies. Some readers thought they could outline it, some said they couldn't, and it may be difficult, but especially when they merge into the normal hypoautofluorescence in the center. Now what about this one? You'll see that the lesions go off the image. They extend beyond field 2 of the imaging field. That one's not going to be gradable. We looked at the atrophy lesion size, and we did this with this multimodal approach. How reproducible could we do this in a neovascular AMD clinical trial? And again, we used this multimodal approach. We used the OCT to define the margins, determine whether there's atrophy, and then we used autofluorescence to do the measurement. And we used some custom software that we helped validate and work on actually at Duke. This is the region finder software from the Heidelberg Spectralis. And we use this to outline the areas of atrophy, to quantify the areas. And what you see is that, and again, this is a neovascular AMD trial, for the small lesions, this is the percent difference, or the difference between the two readers, higher percentage difference when the lesions are very small, and this makes sense because a small difference in lesion size will cause a large percentage difference for small lesions. But once you start to get above 2 millimeters squared, the readers were quite reproducible. We did the same thing with the geographic atrophy study, and the percentage of gradability, very high, 93% for the atrophy area. And you see here the reproducibility is even better for the atrophy, for the geographic atrophy. Once you get above 1.5 millimeters squared, it's quite reproducible. So in the last couple of minutes, I just want to show you some real-life data. This is from the port delivery system study. We were the reading center for the PDS Archway and Portal studies. And this comes from this came from the LADDER study. We were also for LADDER. We used dual reader grading. We used the CAM criteria. We measured autofluorescence, looked at the change over time, and measured the lesion size. And it turned out that when you look at the port delivery system study, there was no significant difference when compared to intravitreal bolus injections, which was a little bit of a surprise, but we were able to do that with this method for assessing atrophy. And here you see the comparison between the intravitreal injection monthly to 100 milligrams per mil port delivery system. The rate of change was nearly identical. Last example, last minute. So we looked at reproducibility in the GATHER study. This is the avacincaptad or Zimura study from Iveric. This is a phase 2-3 study and a pivotal trial for which we served as the reading center. And the primary endpoint was rate of change over time, and we were able to demonstrate a statistically significant difference using the method that I showed you, a 28% difference, and this was the primary study endpoint. And we used the CAM criteria, and we're able to distinguish the treatment from the control groups. So to wrap this up, I think multimodal assessment is useful for geographic atrophy. We see it in non-neovascular and neovascular AMD. This is an approved study endpoint, and you just saw data from one of those studies. And we really need reproducible criteria, and I do believe, at least with the CAM criteria that I've shown you, that at least for the studies that I've shown you, I think these criteria have proven to be valuable. Thank you.
Sorry. Don't go away, Glenn. You're
tried to get away too
thank
fast.
You. I know it was a very exciting talk, so you wanted to drop the mic and leave. But we're going to have you continue speaking to us about GA, and we're going to talk about imaging risk factors for progression to GA. Glenn, can you just make sure you're also talking into the mic, because when you turn your head,
sorry,
not a problem. It's just mainly for the people online who are dying to hear your voice. Thank you, sir.
I will do that. I was trying to speak to my live audience, which I haven't had in a long time, but I'll speak to the virtual audience this time. So we just got done talking about geographic atrophy, and once you get to the advanced stages, but what about the stages before you get to geographic atrophy? What are the risk factors for progression to late AMD? And again, my disclosures are, as I discussed previously, these are the key take-home messages. The intermediate AMD features can predict progression to geographic atrophy. We defined and described these features using consensus, again, in the CAM group. And I would just like to mention David Saraf, one of our illustrious speakers, is a member of that group as well. And these are useful, I believe, in the clinic and in clinical trials, and I think will prove to be so more in the future. So we've had a series of consensus meetings, first to define the characteristics of macular atrophy, and in this presentation I'm going to show you some of the risk factors, and you've heard about some of these from David in his earlier presentation. We decided, as you saw, that OCT is a primary modality for assessing macular atrophy, but we also have decided that OCT should be the primary modality for assessing these risk factors as well. And these are very useful for evaluating progression, the risk of progression to late atrophy. And we believe that they'll be useful for clinical trials. And so this was described, this just came out as a publication for our CAM5 publication for the risk factors associated with geographic atrophy. And many of the figures that I'm going to show you come from this publication. So from the consensus, we will certainly need further clinical trial validation, and I think that once validated, they'll be very valuable for using for clinical trial inclusion for intermediate AMD studies. Ideally, you want to decrease the number of subjects and the duration of the studies, because as you get to earlier stages of AMD, potentially it could take a lot longer with a lot more patients to demonstrate treatment effects, and this should be helpful in this regard. It's also helpful for prognosis, and once we actually have treatments, I think it'll be helpful for predicting treatment response. So these risk factors specifically are particular types of drusen: soft drusen, cuticular, and those with a hyporeflective core, druzenoid pigment epithelial detachment that David just showed you, subretinal druzenoid deposits, intraretinal hyporeflective foci, hyporeflective crystalline deposits, and acquired vitelliform lesions. So let me just show you these examples. Drusen, including large soft drusen, are probably the most associated with progression to atrophy, but also cuticular drusen and those with hyporeflective cores. So large soft drusen are seen on color fundus photography as these yellow spots. There may or may not be associated hyperautofluorescence, and on the far right, you can see that there may be an area of disintegration of the RPE causing transmission, or a cap of pigment which causes hyporeflectivity. Cuticular drusen have a characteristic, there are different types, but the most characteristic has a sawtooth type appearance. They look like little teeth. And you'll also notice that there are these barcoding effect, which you get, you get alternating areas of, if you can go back. Yeah, here we go. So you'll get alternating areas of hyper and hyporeflectivity penetrating into the choroid. Drusen with hyporeflective cores are seen in the middle lower panel on OCT. You see this, what looks like a space within the drusen, and that corresponds to calcium. You may also see spherules, which are hydroxyapatite spherules that cause this crystalline appearance, and these are both associated with progression to atrophy. David showed you the sinking down of a Druzenoid PED. A Druzenoid PED is like a big soft drusen. The soft drusen have medium homogeneous internal reflectivity similar to a Druzenoid PED, but the cutoff for a Druzenoid PED is about 350 microns in basal diameter. They're often associated with a hyporeflective cap that corresponds to pigment usually, and that causes hyporeflectivity, the hypotransmission into the choroid. But the point is that you're seeing these become atrophic as they sink down and then turn into atrophy. Subretinal druzenoid deposits may be more familiar to you as reticular pseudodrusen. We've used the term by consensus now, subretinal druzenoid deposits, to try and better describe what they are. They're not like drusen in the sense that they're not interposed between the drusen and its lamina and the Brooks membrane. These are sitting on top of the RPE. So they're subretinal druzenoid deposits. We don't use the term reticular because they're not always reticular. In fact, in this example, in the color fundus photo, you see these punctate spots. The characteristic appearance is what looks like a hat or a cone poking into the retina. Depending on how advanced these are, they can poke farther in or not. But you may also see these sort of lumps on top of the RPE, and you may also see diffuse subretinal druzenoid deposits. Why are they important? They're important because they're associated with progression to atrophy. They're located most commonly in the superior retina or nasal to the optic nerve, and you can see in this photograph or this image The color fundus photo shows the drusen initially, which then expand over time, and you'll notice that centrally it's progressed to cirrhora. Intraretinal hyperreflective foci are seen in a variety of different diseases, including ocular inflammatory diseases, but we see them in eyes that have non-neovascular and neovascular AMD. It's been hypothesized that the depth to which these things migrate may give a clue as to how advanced or how likely there will be to progress further. The idea is that they start at the RPE and then they migrate towards the inner retina, and what you're seeing is a progression showing these foci migrating progressively towards the inner retina. You can quantify these, so if you create a slab and look at the en face image, you can then measure the number of these hyperreflective foci, and then you can correlate this with rate of progression. Hyperreflective crystalline deposits are one of my favorite. They are very dramatic, and you see this hyperreflective lesion. They were originally called hyperreflective plaques, but they're not always plaque-like. They take on this sort of needle-like appearance. They don't always sit on the RPE or on Bruch's membrane. Typically, these are interposed between the RPE and Bruch's membrane, and they can migrate, they can change, they can go away, they can come back, but they're thought to be cholesterol deposits, which distinguishes them from the hyporeflective cores in the drusen, which is from calcium. So it's not calcium, this is cholesterol. And they appear very bright. You can see there's a mixture in this particular image of the crystalline drusen, the drusen with the cores, and also at the yellow arrow, they're very bright on color fundus photography. You may see hypoautofluorescence because there's often associated atrophy, and that's what you see in this image right here. Acquired vitelliform lesions are very important because you have to distinguish those from macular neovascular lesions. They appear yellow on color fundus photography. With fluorescein angiography, they're initially hypofluorescent, and then they become hyperfluorescent later in the angiogram. On autofluorescence, which is particularly important, they are hyperautofluorescent, and that can distinguish them from the neovascular complexes. It is subretinal hyperreflective material, so it's interposed between the outer retina and either on Bruch's membrane or more commonly RPE, but these predispose to atrophy. But you can confuse them if you're not careful between a macular neovascularization. So macular neovascularization, as David shows you, can cause subretinal hyperreflective material, which is either fibrin, blood, choroidal neovascularization, scar tissue. But these are made of something different. These are the shed photoreceptors. They're RPE mixed in with some organelles that have been expelled. And they are hyperautofluorescent, as I mentioned. Sometimes you can get what looks like subretinal fluid sitting on top of these vitelliform lesions, but this is not exudative. You don't see intraretinal fluid, and so you need to distinguish these from macular neovascularization. I have seen physicians who have referred patients in to me who have treated these eyes for macular neovascularization. They wonder why they never get better. It's because it's not neovascularization. It's these acquired vitelliform lesions, and they're important because these progress to atrophy, or they can progress to atrophy. And here you see illustrated in this slide an acquired vitelliform lesion. This particular one was yellow with some pigment in it, which gives the appearance, as you see in the panel B, the elevated lesion with a hyperreflective lesion within it. But you also see that this progresses to atrophy. So that's important to recognize these acquired vitelliform lesions. So just to summarize, the lesions that I've shown you are particularly valuable to identify because of their rate of progression to geographic atrophy. The terms that we're using, and some of them may not be as familiar to you, the hyperreflective crystalline deposits, for instance, the use of the term subretinal Druzenoid deposit instead of reticular pseudodrusen. These are things that we came up with by consensus that we hope will be used going forward. And I think ultimately, especially once we get more validation in clinical trials, will prove to be useful. Thank you.
Thank you, Glenn. I'm going to welcome Peter Kaiser, one of the hosts of this meeting, who literally just flew in from Cleveland. Peter, are you going to do the panel, or are you going to give the...
Well, I tried to, I put these together on the plane, and then my computer died.
All right, so I don't know what he's
And
going
it's
to talk
dead
about.
out
It'll be
there.
interesting. So,
So
Peter
I'm just
Kaiser
gonna-
Potpourri.
So, yeah, right. Sorry I'm late. Here are my financial disclosures, none really relevant, except that we are part of the Zeiss team. So this type of patient is something we're starting to see more often, which is a patient who comes in, obviously with macular degeneration, and complains of vision impairment in the left eye. And so if we look at the OCTs, maybe I'll do this like a panel. How about that? Would that work for you? All right, good. So, Sunil, what is that arrow pointing at in that left eye?
The arrow there is pointing at, it looks like to me, I see RPE thickening. I'm not sure that's subretinal hyperreflective material. I think that's thickened RPE personally to me. And then are you talking about the hyporeflective material or the hyper?
Just the whole kind of complex of that red arrow.
Yeah.
Well, let me ask you the next question. What would you do next? I mean, this patient comes in complaining of decreased vision in that eye. Is this just dry?
Yeah, to me, this is what sort of Glenn just showed us. This is suspicious to me of non-neovascular disease. I would probably image the patient more, and I'd probably get a fundus autofluorescence, and even consider an OCTA or a fluorescein if I wanted to really go down this path. But so that's where I would go.
So here's your OCTA. Left eye, right eye.
So and here you're seeing nicely on the OCTA the presence of a neovascular complex on the ORC scan, which highlights that this is probably at some level a neovascular complex, but there isn't intraretinal fluid or subretinal fluid at this point. So this is what I think a lot of us call the non-exudative disease, if you will. So you have at least what looks like a neovascular complex, but no intraretinal or subretinal fluid yet.
So David, you're the smartest person on this panel. When do these patients leak? Do we ever have to worry about them? When would you see this patient back? What's your sort of discussion with them? Because they just told you I've got some decrease in vision in that eye.
Yeah, this one's a little bit trickier. I mean, typically with non-exudative neovascularization, you see a shallow irregular PD, what we refer to as shallow irregular RPE elevation or SIRE. I think Glenn has mentioned that term too in that beautiful article he wrote. But in this case, I look at this as just some Schrem material. And I showed a case where a patient had a larger area of Schrem. He was symptomatic, 2150, and we actually treated it and the Schrem went away. Typically with more classic cases of non-exudative NV, I'll watch them. But this one would give me a little bit more cause for concern. I'm not sure if Glenn would agree.
Yeah, I agree 100%, because to me, when you first showed that, I thought it did look like subretinal hyperreflective material, which corresponds frequently with type 2 choroidal neovascularization, which we definitely would treat. Yes, we didn't see fluid specifically. It wasn't thickened RPE because you didn't see hyporeflectivity in the choroid. But to me, that looked a little more exudative than non-exudative.
You know,
I'd
and we can
expect to see the low-lying type 1 RPE detachment as a manifestation of the non-exudative. You get that sort of tram track or double layer sign.
You know, and this signature also looks very similar to what we see in myopic CNVs and inflammatory CNVs, where you may not have as much fluid there, but you certainly, especially with the symptoms, I would lean a little bit more towards
Often no fluid
Yeah.
in the myopes. So I would agree. You might actually see resolution of that material with anti-VEGF injection.
You know, and this is a topic that's really starting to come to fore, which is this idea of non-exudative neovascular AMD. And, you know, originally when Phil first described this or first mentioned this, he called it the double layer sign. We've since retermed it, seen on ICG, best seen, in my opinion, on OCTA, easiest to see. How often do you do ICG with this, Glenn? Do you do it often, or?
No, I like to do OCTA.
And when you look at your OCTA, what slab do you use for those of us who don't run reading centers?
I usually will use the avascular complex, but in the presence of a PED, you have to be very careful because the standard slabs may not actually catch the area that you want, and you may be getting part of the PED, you may be getting projection artifacts. So I will usually look to see where the elevation is and then use the slab to contain that area. Look to see where the RPE elevation is and use the slab to contain that area. Otherwise, you can get messed up with artifacts.
So how precise do you think it is? Because I bet you, so Sunil and I run clinic next to each other, and I bet you I could show him an OCTA, and depending on what you want me to show him, I could either show him a CNV or I could not show him a CNV. Are there tricks to how you do this?
Yeah, so I like to look at, you can look at the on-FOSS image and you can get a beautiful picture like that of the CNV, but you can miss it completely, or you'll see what look like vessels if you haven't defined the slab properly. And I like to look at the cross-section, the B-scan, and on the B-scan you'll see the little dots from the flow pattern, and that helps to, and that's exactly right. So you see those magenta-looking dots, I'm assuming, which are the flow, and then you can create the slab to contain those dots if you want to see the vessels on FOSS. But I actually use the B-scan most commonly with the OCTA. And you can avoid artifacts that way.
Yeah, I totally agree. So let me just show you this, which I think is interesting. So in many of these cases, we would have termed this back in the era of like MPS, PDT, occult CNV, right? Type 1 lesion. And for those of you in the audience who don't remember PDT, we didn't treat them until they had disease progression. So in other words, what we're now calling exudation. But like when you watch these for long periods of time, they grow quite a bit. Is there, and in a disease progression definition, if they grew, that would be a reason to treat. Is that a reason for you to treat these? Let's assume no exudation. You're just watching this patient with the OCTA, and it's getting bigger.
I don't think that we're that good at halting the progression with our standard treatments with anti-VEGF therapy. I mean, we've shown that, for example, in CAT, we've shown that even when you do treatment, the lesions keep growing. And so I don't know that just the growth of the lesion would be an indication for treatment with at least anti-VEGF agents, because I don't know how well we're even going to stop the growth.
Or that will change outcomes.
Or that it'll change the outcomes, especially if what we're thinking is that the growth of these lesions may be adaptive and that the eye may be trying to grow these to help provide nourishment to this diseased retina. Until it starts creating exudation and then causing photoreceptor damage, et cetera, it actually may be helping support the retina. And I've seen these. I have a patient I just saw yesterday, for instance, who I've been following for years and years. The lesions have grown, but her vision has been very good. Occasionally you'll get breakthroughs, and you'll need to treat them, but sometimes you'll treat them and then they'll stay stable for a long time again.
Yeah, and I think this is a very important point, because I'm just going to move to my last slide here, which is this one. Because we're starting to see this idea that not all CNV is CNV, especially when we look at both the Gather 1 study and the recent Derby Oaks as well as Philly study. This idea that the CNV that we need to worry about is exudative CNV, right, as opposed to what I've just been showing you, non-exudative. And just for those of you in the audience, if you look at sort of the negative predictive, can you go back one slide for me, please, in the back? Thanks. If you look at the positive and negative predictive value of this double layer sign, one more slide, sorry. Two more slides, this one. You know, if it's not there, you feel pretty good. If it's there, that's when you have to start worrying. And then when you look at when these exudate, it could take a very long time, if not. In Philly, about 70% were exudative within about a year. That's, of course, in patients who are receiving a drug. So, you know, we don't know if that would be the case if you received absolutely nothing. But this is something to watch out for. I think it's pretty easy when you start to look at the signal on the B scans to recognize this without an OCTA. So for those of you who don't have OCTA, you know, don't freak out and say there's no way I could ever make this diagnosis, because to me you can make this with just your regular old swept spectral domain. You don't need a swept OCTA to figure it out. So let me move now to the panel discussion, because I think that was my last slide, yeah.
We have a couple questions from the online community, if I can ask. Is that all right?
Sure.
So, Glenn, one of the questions that came was progression of, what would you say is the best predictor for progression? So the question specifically is progression of specific perimeter boundaries of GA areas is best defined by what? Outward loss of the RPE, outward photoreceptor loss, fundus hyperautofluorescence. What is your idea is the best predictor, you think, of all the signals that we have the ability to look at?
Are we talking about atrophy that's already present and then?
So somebody who has atrophy, and if you wanted to essentially assess risk to that patient of growing that atrophy, is there?
Yeah, so one of the features, I alluded to this in the presentation, multifocal lesions tend to progress faster. Lesions that don't involve the fovea tend to progress slower. And I think we're going to have a nice opportunity we're actually analyzing it right now, but also in the GATHER2 study. In that study, unlike in the Philly study, for instance, patients had to have no center point involvement with the lesions. And one of the questions is, how fast do the lesions grow into the fovea in these cases? Presumably, they grow more slowly into the fovea in general, and that's why people's vision can be maintained for longer. So if you have lesions that don't go into the foveal center, they grow more slowly. So those are some of the features that either go with faster or slower growth.
So the other thing I think, Glenn, which would be great for the audience to understand, so extrafoveal, in the definition we used to use, was 200 plus. What is the definition of extrafoveal in GATHER, Oaks, Derby, for instance, the GA studies?
In GATHER, the fovea means the foveal center point. So, you think of the fovea, you think of a 300, 400, 500 micron diameter circle. And some people think of the center subfield, but actually in that study, foveal involvement means the foveal center point. So it isn't 100 microns or more. There's a study that's just coming up that's going to be started that includes within, I think it's 100 microns of the fovea, calling it foveal involvement. So that's part of the problem, I would say, is that the studies have not been completely standardized in the way they define foveal center.
Yeah,
Or the way they define foveal involvement, I should say.
Yeah, or how they define extrafoveal.
Yeah,
right. So in some studies, they're defining it as more than 1 micron out of the center of the fovea, and that's why I wanted to kind of let people understand that. It's a totally different way. The definition is moving, and different companies call extrafoveal a different distance. So as we'll have Glenn write a white paper with David, and we'll all know what we're doing.
Go ahead, man.
Glenn, can I ask a question on your multimodal measurement? I mean, obviously right now, as we're transitioning through our technologies, having that dual or even more than dual validation of what you're seeing is so important. Do you see in the future, though, that we just totally transition to OCT in terms of the actual measurement with densely, obtained scans in these, or do we still continue to measure on fundus autofluorescence images?
Yeah, it's a tricky question. We've actually looked at this. It's a good question, and it's tricky because you're looking at slightly different things. Fundus autofluorescence is really a functional test. You're measuring the health or absence of the RPE and whether there are fluorophores there or not, whereas with OCT, it's a structural definition, and the OCT methods for looking at atrophy include looking at the hypertransmission because of the missing RPE, and you can create a slab and then get a outline that looks just like the atrophic area. The problem is that that doesn't always work. The correlation is not 100%. So with OCT, you can have basolaminar deposits sitting on the RPE, and they can be quite thick. In an area of atrophy, leftover basolaminar deposits after the RPE is gone, and that may affect the signal penetrating into the choroid, and so you may not be measuring a completely accurate assessment of loss of the RPE in that case. And so I don't know that we're going to go to 100% OCT for that reason. I think both, they complement one another, but you do get different measurements depending on which modality you use.
Well, and it's interesting, as we go to a CRORA-based definition, whether or not using in some way the B-scan and translating it and interpolating it rather the ONFOS in the OCT, whether there will be a role for that as well with some of the newer assessment technologies.
There is, but then you run into the problem where you have a B-scan, which is a horizontal raster scan, and you're measuring the diameter in one orientation. But these lesions aren't, as you can see here, they're not always perfect circles, and you can't always identify the exact greatest diameter along a horizontal, and so you have to take into account the irregularity of the lesion as well. So it starts to get more complicated.
Hey, Glenn, for the last 2 points about the center point or extrafoveal, as well as this definition of using either OCT or autofluorescence as an endpoint, have we got any guidance from regulators as to what they're looking at?
We haven't gotten guidance from regulators. I will say, though, for looking at the relationship to the foveal center and whether it's extrafoveal or not extrafoveal, OCT is by far the way to go. It's very difficult. This is a good example here, I think, that in this image that you're looking at, it's hard to distinguish the normal foveal hypoautofluorescence and then try and figure out exactly where the center of that is compared to the surrounding pathologic autofluorescence. So I think OCT by far is the best way to go. And I think you're going to start to see more actual quantification of different parameters of the atrophy, extrafoveal atrophy, as it moves towards the center as defined by OCT. And we're actually working on an analysis of that right now.
So Teddy, we have some pretty good results from a phase 3 or 2 phase 3 studies. In the past, when I would ask this question, how do you follow dry AMD, many people would say as little as possible. But now we're going to be having to show patients that an injection monthly or every other month is actually doing something when their vision hopefully is 20/20. So how do you anticipate using imaging, let's say next year when hopefully we have a drug?
So I think there are several different ways that we can be using the imaging. One of them is to determine some of the characteristics of the lesions that responded best to the drug. And this is, Genentech, Roche, for instance, has a big AI initiative for personalized medicine where they're evaluating their images to see what characteristics using an AI-type algorithm predict response to their drug. And I think we're going to start to see more of that also with geographic atrophy as well. The other question is, how do you convince somebody in the clinic that when they're seeing 20/20, and a lot of these patients still do see 20/20, how do you convince them that it's a good idea to give them injections in their eyes at some relatively frequent frequency? And I think the patients start to learn how to look at these images really quickly. For exudative AMD, it's pretty easy, and you can teach somebody in about 30 seconds how to look at a OCT and tell whether the fluid's getting better or not getting better. And I think we're going to have some better tools that will show a patient what's happening to the progression of the atrophy in their eye, and I think that will also be helpful.
Question, please.
Quick question, Dr. Saraf. In reading the paper Non-Neovascular AMD with subretinal fluid, in those really large PEDs with overlying subretinal fluid, how can you be confident when evaluating it with an ICG that there's no neovascularization? Are you concerned that the PED blocks some of the ICG transmission? So that was one thing that had me confused in reading that paper.
Yeah, that's always, I think, a concern. I don't really avail myself too much with ICGA and fluorescein angiography. Fluorescein angiography can show leakage and staining even in non-neovascular contexts. So really I rely on the OCTA, but to be honest, the OCTA is not 100% sensitive, and you actually have to play around with all the different segmentations that we're talking about. So I'll use the ORC, the outer retinal segmentation, the choriocapillaris segmentation. I even have a customized segmentation along the RPE monolayer. So we'll look very carefully on the OCTA to see if we see any evidence of neovascularization, but it's not always 100%. It's always helpful as well to look for other signs, heme, or the presence of intraretinal fluid in association with subretinal fluid, or the morphology of the PED, all of these things can factor into my ultimate decision, which is whether to treat or to observe.
So in clinical practice, you're always treating actually those even non-neovascular lesions because you can never really be sure. I mean, if it doesn't improve, maybe you can have that thought. I suppose,
That's another study that we're doing, is looking at the effect when we don't see neovascularization on the OCTA. By and large, I would say when there's no neovascularization on the OCTA and you're more confident that the fluid is non-neovascular, you observe the fluid. It doesn't typically respond to anti-VEGF, and it typically doesn't progress after you observe it. So what I'm starting to do in these patients is what I refer to as an observe and extend, when I'm more comfortable that the fluid is non-neovascular. And it can have, you could say, oh, why not just treat? It's easy to treat. Let me tell you, I've had some patients who've been non-neovascular that have been treated for 3 or 4 years unnecessarily. So I think it's an important differentiation, an important identification to make. You have to be careful, though. That is exactly true. You have to be careful that you're just not missing the neovascularization. So when I do that observe and extend, I'll start with a very short interval and gradually extend it if I'm comfortable that actually the patient is non-neovascular.
David, do you ever consider in those contexts doing an anti-VEGF trial? It was setting out with that thought process with the patient where you say, we'll do 1 or 2 injections, we don't think this is exudative, and then get them off.
Yeah,
do you use that at all?
Yeah, I do. That's another approach. Again, I wouldn't say it's a hard and fast rule, but generally speaking, when it's non-neovascular fluid, you don't see as much of a response. The fluid that just kind of sits there in that relatively mild quantitative level and doesn't change, but that's something I'll use as well. That's a good point.
I think the discussion brings up something important about an unmet need for imaging in clinical practice, that in the practical interpretation, because as you've heard from David, as I've mentioned, to look at an OCTA to try and figure out if it's an artifact or is it a neovascular complex takes more than you may want to be spending in the clinic. It takes more time than you may want to be spending, especially if you have a really busy clinic. And I think one of the advances that needs to happen is to have more automated interpretation that's accurate for the assessment of whether there's neovascularization. I think some of the AI approaches are going to be helpful in that regard.
All right, so I think to stay on time, we'll have our break now. We'll break for 20 minutes, and for the online audience, we'll be returning 2:30, what are we, Central here?
2:30 Central, yes.
Central time. For those of you who are here, please visit our exhibitors. Don't forget the exhibit passport, because there's cool prizes you could win if you have your passport all filled out. So we'll see everybody back in about 20 minutes.
All right, everybody. We're going to go ahead and get started with our next session, which is going to be our retinal disease imaging section. To start it out, Catherine Talcott's going to talk to us today about integrating OCTA into your clinical practice.
Thanks so much, Justice, for the introduction. Here are my disclosures. The other disclosure that I will mention is that I am not an OCT expert, unlike some of the people on this esteemed panel. And, you know, when I was sort of putting together this talk, I did it from the perspective of someone I've been out of training now for about 3 years, and while I was in training, we didn't do a lot of OCTA imaging, and then I've come to Cole, where there's a lot of OCTA imaging available and a lot of discussion about it. And I'm still trying to sort of figure out what's the best way to sort of utilize OCTA in your practice, sort of like where can it be helpful, and how best to sort of interpret these images. All right, so if you look at the literature, there's been an explosion of research publications on OCTA really over the past decade. But if you look at things like the PAT survey, this is the one from 2020, only a minority of retina specialists, about 30% of retina specialists in the United States, have access to OCTA and actually find it useful. So how do we put these things together? Why, if we have, you know, great imaging tools, why don't we use OCTA? And, you know, I come to these sessions, I learn a lot about imaging. I love looking at the beautiful pictures of CNVs seen on OCTA, But then I go back to my clinic, I'm in the middle of seeing like 50 patients, lots of people who need injections, and I get an OCTA on someone who has, a little subretinal fluid, trying to make sense if they have a CNV or not, and then I look at a picture like the one on the right, and I'm left thinking, is this a CNV? Is this not a CNV? Sort of, what do I do? So, I think that some of us sort of experience this disconnect of sometimes the images that are presented and actually utilizing it in our own practice and sort of what to make of that. So there's, and I don't think I'm the only one who has some difficulty in interpreting these images. This is a study that looked at 38 retina specialists who were facile in the interpretation of OCTA images, who looked at images from 12 different eyes, and they compared them. And overall, the data did not demonstrate that there was a lot of agreement in between the people who were looking at these OCT images. And even when they looked at sort of the years of practice or where you practiced or how often you used OCTA, it really didn't make a significant change on how much the readers sort of agreed about these metrics. But then there's other studies that show that OCTA can in fact improve the way that we take care of patients, and especially in being able to see if there's a CNV or not. This is a study that looked at sort of CNV qualities on OCTA, and also looked at the detection of CNV by OCTA using sort of FA as the gold standard. And they found that the sensitivity was 50% and the specificity was 91%, but the sensitivity was close to 100% in type 1 CNV lesions. This is another study that sort of compared looking at patients who had potential CNVs using FA, OCTA, and OCTA and OCT combined using 2 mass graders. And when mass graders just looked at the CNV, they found that the sensitivity was about 66% for finding a CNV, versus OCTA, it was pretty similar, but when you used OCTA and OCT together, it really improved. So really, other studies have shown that when you combine OCTA with OCT, it can really increase the sensitivity in between graders. So let's take a step back and just sort of talk about sort of basics of angiography. So OCTA uses motion of red blood vessel cells against a static background to be able to identify if there's retina vessels present or not. It requires a high-speed OCT, motion correction, and en-face imaging. Here's sort of a schematic looking at how OCTAs are generated using OCTA volume data. You get a bunch of B scans sort of looking at flow, and these frames are put together in order to create a 3D OCTA volume. And that allows us to have OCT visualization of different layers attained then by when you slice those B scans and project them using the OCTA data. And we get a number of slabs to be able to look at different layers of the retina to be able to get information. Here's another way of sort of looking at the way that OCTAs are segmented. So there's a superior retinal plexus and the deep retinal plexus. In general, these can be really helpful for being able to determine if there's retinal vascular problems. Another slab that you can look at is the outer retina, which is normally avascular and can be really helpful to see if there's a Cnvm present or not. And you can also look at the choriocapillaris, where you can look at if there's choroidal vascular problems. So in general, there's a lot of benefits to using OCTA, like we talked about in the past session, that allows us to visualize flow in microvasculature by detecting motion contrast from moving red blood cells. It allows us to get 3D images of the retina, choriocapillaris, and the choroidal vasculature. It doesn't require a dye injection, which it can be faster than FA or ICG. So it's helpful and quicker to get if you're in a busy clinic taking care of a lot of patients, or if it's you as the physician who's having to inject the dye. The images in general are sharp. They're not obscured by dye leakage. But, but there are limitations to this technology as well. The imaging is slower to get than getting just a general structural OCT. You need high-speed instruments. It can't always detect if there's slow flow or flow impairment. You can't assess what the permeability of the vasculature is. And then what I've personally experienced is that there can be artifacts, and it really requires careful interpretation about how to do that. I think it's a little different if you're there with sort of an attending as a trainee, or you're discussing at an image conference what to make of these images. But when it's just you and you're having trouble sorting through what's artifact and what real, it's hard, and it's hard to figure out what you're seeing and what that means. But OCTA in general is improving really rapidly. On the left is an example of a patient with diabetes who had a 3x3 millimeter OCTA. You can see the superficial and deep plexuses back as, going back to 2016, where you can see capillary changes and some dropout. And then this is a beautiful example of a patient with diabetes where you can see the dropout here on the right, which just shows really how far this imaging has come. And sort of another sort of teaching pearl too is that, looking at these smaller scans like the 3x3s are really helpful for being able to see if there's a CNV or their foveolae vascular changes. But looking at these broad images are really helpful for patients who have like RVOs or diabetes to be able to see where dropout is. And here's another example of just the technology getting better. These are increasingly larger scans, a 3x3, a 6x6, a 9x9, and a 12x12, where you really don't lose as much definition as one would think, even though you're getting this much larger scan size. So here's a little bit of a discussion with some cases about how OCTA can be helpful for ambiguous cases. And I think this, for me, is the place where I'm integrating it into my practice and trying to be able to determine who needs to be treatment, who needs treatment, who doesn't, and sort of what's affecting patients' vision and not. So here's an example of a 48-year-old patient who has a history of wet AMD in the right eye and dry AMD in the left eye. Vision in the left eye is 20/60. They happen to get a fluorescein, which doesn't show there's any dramatic leakage on that side. And on the OCTA, you can see a nice net on the right eye. In the left eye, you can see this image, and I would sort of be left thinking, is this a CNV? Is this not? What do I make of that? But when I look at the OCT, I really don't see subretinal fluid, intraretinal fluid. So this patient was watched. They come back 2 months later. The vision is dropped in this eye. The FA sort of suggests that there might be some leakage there, but not like definitive. And then if we look at the OCTA, though, 2 months later, you can see that a nice net has developed, and I think gives us a lot more confidence in sort of determining that this patient would need an injection. And I think what I found personally, one of the most useful cases for these is if you have patients who have sort of chronic subretinal fluid, if they have CSR, or if they have a vitelliform lesion, it's your first time seeing them, how to tell if there's a Cnvm or not. And here's a beautiful example of this. I think one of the things that potentially we could talk about in the panel is, that I found in my practice, is if I get OCTAs on this patient and I see a net, great, fantastic. If I don't see a CNV net, though, I think I'm still struggling with how often do I repeat this imaging on patients, sort of what do I use for my guidance if I don't see a definitive one. All right, and then here's an example of a patient who I just saw in clinic yesterday. This is a patient I've taken care of for a few years. She has a history of wet AMD in the left eye, and then she has previously dry AMD in the right eye, and her vision's 20/20. I got this OCT. You can see that there's a little subretinal hyperreflective material, and you can see some hints of some subretinal fluid there. But when I compare to her sort of OCT 6 weeks prior, it looks different. She's very reticent and worried if this means that she has wet AMD in this eye. It'd be harder for her to drive to appointments if she's getting injections in both eyes and what it means for her vision. I got a quick OCT in clinic, and I feel more comfortable that there's a CNV that's there that I can treat. I think one of the other cases that I've sort of have found helpful for these types of patients is actually being able to look at patients who have sort of longstanding diabetes, and their vision sort of is not really well explained by their OCTs. Here's an example where you can see that these patients can have enlarged FAZ zone. And I think the OCTA can be helpful in helping to distinguish if patients have diabetes or RVOs, and you can see that they have some vascular abnormalities that you can see on the OCTA that you really can't see on the FA. And, in other cases, these images are really pretty and help to confirm sort of our exam. This is a 43-year-old man who has hypertension, 20/30 vision, and some spots in his vision. His venous filling is a little delayed. We're worried about a CRVO, but you can also see that there's retinal hyperreflectivity on the OCT concerning for PAM lesions. And I think OCTA, there's been a lot of literature to discuss different patterns that are sort of characteristic of this, but you can see capillary changes temporally to sort of correspond with those lesions. So here's sort of where I run into difficulties, how to sort of interpret these patients. They can have lots of artifacts, media opacities, motion artifacts, projection artifacts, segmentation errors, and visual vessel artifacts. And poor signal strength obviously make these all worse. You can have media opacities where hemorrhage, where it's harder to get imaging. You can get motion artifacts where saccades can appear as thin white lines in these patients, especially if you have older patients, harder to get in and sort of stay focused. And projection artifacts, although the technology has gotten a lot better for eliminating these. And then I think this is one of the ones that I struggle with is segmentation errors. In the below patient, they have MACTEL, and you can tell that on the slabs, the segmentation was incorrect. I think the hard thing is ideally we would sort of go back to the machine and try and, look at the segmentation, but I think it's harder in practice to sort of integrate that. So in order to sort of optimize OCTA in general, I think, at least me as a provider, I think one of the ways that I see that things need to improve is how do we interpret these? I think the things you can do, compare these to structural OCT scans, look for artifacts, continue manually adjusting them. But in general, I think OCTA can be a useful tool for really assessing the retinal and choroidal vasculature. It can be really beneficial in detecting Cnvm and looking at how much oxygen the retina is getting. But I think FA and OCT really have a significant role. But I think we need to continue using OCTA. It's going to continue to get better, and we're going to get better at reading it. I want to thanks for everyone's help who helped me with some pictures and slides. Thank you.
Great talk, Kat. Again, we're going to save questions for the panel. It's my pleasure to introduce our next speaker, Sunil Srivastava, who's going to talk to us. We're going to be changing diseases a little bit. Talk to us about imaging and uveitis.
It's the disease no one wants to talk about. You have to stick me somewhere on the panel. Here I am right now in retinal vascular diseases. So uveitis can be challenging. That's why I get my one talk. So severe vision loss occurs in a fair number of patients. Our best therapeutics. I think this is actually the old talk, because if this is, it's going to be a lot longer. So I'll run through it. Imaging and uveitis. Yeah, I think so, because I think I have like twice as many slides. So imaging and uveitis can solve many of these problems. It can help us identify patterns to assist in diagnosis. It can identify features to explain symptoms. Ultimately, though, it's limited by human interpretation. So the key here for us is to interpret these and solve some of these issues. How much should you image? And this is where this talk comes from. Of course, a careful clinical exam is needed. Of course, a careful history and review systems. And of course, you want to develop a differential diagnosis. But in the beginning, I ordered as much as you can. When you're first out there, I think you have to do this sort of stuff. In the beginning of my career, this was 15, 16 years ago, I think I was well trained. I thought so. Glenn told me when I left Duke that I was kind of average, so I took that to heart. But what changed in the first couple of years of my practice was better imaging came around. OCT improved, it got better, the software improved, and we were really exposed to wide-field imaging at this point, which really fundamentally changed how we can manage uveitis. So how do you choose? This first bullet point is how I think about this. Where do I think the inflammation is, and is there an imaging test that highlights that area better? Can I use this test as an outcome measure to follow patients? So will it improve on steroids? Will it improve on antivirals? Do I expect this imaging finding to get better? So I use wide field photography a fair amount, especially when I can't see. OCT for almost everybody, OCTAs maybe for those who I'm concerned about CNVs. And then angiography is basically the workhorse in my uveitis clinic. It does a ton of the imaging for me because I usually end up with an outcome measure that I can follow, and I still use ultrasound as well. Here's the scenarios where I want you to remember to over-image. And so if you're really talking about multimodal imaging, you're really talking about over-imaging. You're going to probably get some imaging tests that after a while you'll say, I didn't really need that, but I wanted to make sure I wasn't missing something. But in my head, this is how I think about the patients and what diseases I want to over-image. Steroid-resistant disease, people who have recurrent anterior uveitis, especially young ones or older ones, lots of inflammation but not a lot of cystoid macular edema. Anybody who walks in with a diagnosis of presumed ocular histoplasmosis or anything that's called white dots, I want to get an image of those patients, inflammatory choroidal neovascular membranes, and of course, retinal vasculitis. So let me show you a couple cases. So this is a 62-year-old male who has a history of uveitis who presents for a second opinion. 2.5 years ago, rapidly developed a cataract, and within several weeks had cataract surgery, but still couldn't see very well. In the past couple of months, he has had multiple injections around his eye, in his eye, and he's been started on Humira as well as methotrexate, really without any improvement in his vision. He's 2100 in that eye and 20/20 in the left eye. This is the old talk, so I'll run through some of these slides really quickly. So here's the image here on the right eye, and you can see the fundus photography, which already starts to give you a clue. You can see some changes in the inferior retina, some pigmentary changes. There looks like there might be a little elevation there nasally. The left eye is completely normal. The OCT confirms this kind of choroidal elevation that you can see. So immediately I'm thinking I want a fluorescein and ICG in order to help myself out. Here's the fluorescein that, again, highlights this pigmentary pattern that kind of starts giving you a clue. Some people would even call it leopard spotting here. So this is a clue to us that maybe something occult is occurring. The left eye looks completely normal. And then the ICG doesn't really help me out. I kind of already knew there was something in the choroid and the ICG. I over-imaged in this patient. Really didn't really make a difference. So what are my thoughts here? Well, I think the most important thing when some of these patients are going through this, when I have somebody who's on high-dose corticosteroids or a lot of immune suppression and not much is helping, I start to say to myself, maybe I should start imaging these patients or looking at these patients when I take them off steroids. I'm a referral-based practice, and sometimes I take patients off immune suppression in order to figure out what they're going to look like. What else should I order in this patient? Well, I already have a clue in my head that this is probably something malignant. And so when I see the subretinal RPE elevation with pigmentary changes in somebody who has chronic uveitis, I'm going to get an ultrasound. And the ultrasound here is the key. You can see these peripapillary hypoechoic spots just posterior to the sclera. This points out to me that this patient probably has choroidal lymphoma, and when you take them off the steroids prior to biopsying the patient, you can see the area where you're going to biopsy and confirmation that this is lymphoma, malt-like lymphoma, and this is the patient, what they look like post-radiation. So what's the take-home point is someone who's not responsive to steroids, and when you're going to image these patients, obviously you're going to get imaging, multimodal imaging, but consider getting these images also as you take patients off the steroids, or especially when you're about to biopsy them. That will help you a lot. Seeing that difference can also make a difference for you. Let me show you a second case scenario. A 13-year-old male who comes in with a pink, painful, blurry vision for several months, pink eye in both eyes, endorses eye pain, noted to have recurrent anterior uveitis, which was treated topically with multiple recurrences. When you look at his vision, he's 20/20 and 20/50. He has cell in the AC and in the vitreous of both eyes. The fundus view looks pretty good, but you can notice there's some small little whitish spots into the periphery, especially nasally and temporally in the right eye. And you'll see it here in the left eye as well, multiple small little spots, especially nasally, inferior nasally in this left eye. So already when I see this patient, I know, well, I want a fluorescein. It's a 13-year-old. Doesn't matter. You're getting a fluorescein. That's just the way it's going to be. We got to figure out what's going to happen to you, especially when I see an OCT like this. It looks really normal. You'll see some vitreous cell, but how do I explain 20/50 vision in this 13-year-old? I need to get an angiogram to really kind of give me an idea what else is happening. And you can see on the angiogram, some of those spots start to light up. In the early and in the late, you get this little peripheral leakage that helps me out a lot. Okay, I know activity in the posterior segment. I know activity that's probably been there for some period of time because I have this kind of occult leakage that's been occurring. And in the left eye as well, you can see much more prominent leakage, especially around the nerve. I can explain the vision loss. But because I saw those spots, I also wanted to get one other test. This is a place where the ICG helped me out a lot. And all of a sudden, I can see that these spots light up more than I could see on clinical exams. So here's where an ICG makes a difference for me. This is no longer just, pan-uveitis. This is multifocal choroiditis. So that changes my differential. I think I got a 13-year-old male with vitritis and multifocal choroiditis. The lab image is already pulled up. We can't wait to see what's elevated. But here are the things that I'm thinking of, and it turns out this child has TINU, tubular interstitial nephritis and uveitis syndrome, highlighted by the urine beta-2 microglobulin, which is elevated. This is something that we're seeing more and more of. I'll highlight a paper by one of my partners, Sumit Sharma, that actually described the ultra-wide field fluorescein changes and OCT findings in these patients. This is not just anterior disease. This happens a fair amount in the posterior segment, and having this kind of information from multimodal imaging can make it easier to recognize this disease. I show these cases, and I show this for a really important reason, is that imaging, especially fluorescein imaging in the teenage group, is something that I think we need to do more of. And the reason is you can use this as an outcome measure to see how patients are doing. It's uncomfortable to do a fluorescein on young people, I get that, but it can be really, really helpful for following these patients. So pediatric patients, especially teenagers, I think we're under-imaging. I use wide field fluorescein to determine activity, to figure out where the inflammation is, and if they're active. And the reason is we've shown in multiple papers that if you don't do fluorescein, especially if you don't do wide field fluorescein, you're missing a fair amount of activity. So you can miss up to 50% of patients who have some sort of activity, and fluorescein is an incredibly sensitive way to determine activity in patients who have uveitis. So in cases where you can't do an IV fluorescein, oral fluorescein works great. Here's a patient who I did oral fluorescein on. You can actually get some really nice images. You have to take it with a grain of salt, but you can actually get some really nice images that show me activity and maybe even a resolution of activity by using oral fluorescein. I use fluorescein in these kids to help me identify when they're active and how to control them. So this is a patient who has this peripheral leakage. This is a 14-year-old patient, and they're not really responding to therapy. I switched therapy. They're now on adalimumab. I think that they're better. But 9 months later, they still have a relatively normal OCT. The vision's pretty good, but their leakage gets worse. So we're trying to decide what to do next. And the really interesting thing here is when you see this OCT that as I'm trying to get them onto new medication, Look at the change analysis, the next visit. So this is now a year of them having relatively normal OCTs. This is the first OCT where we start to see cystoid changes. And now look at the leakage that you're going to see on the, I'm sorry, I didn't show you the leakage very well, but that's how long it can take. It can take a year, 15 months of leakage before you get macular thickening in some of these patients. So some of these patients have been brewing for a while and we've missed it. It's not until they start Remicade that we actually see improvement. This is them now 2 years later about to start college, where we now can make a decision. Now we can pull you off therapy because you've been quiet for this long. So I think in these cases, use wide field photography. They're great in tough eyes. Children, small pupils, and if you're not comfortable doing a dilated fundus exam, of course, everyone here does a great dilated fundus exam. Maybe not Peter, but everybody else does a pretty good dilated fundus exam. But you can use your wide field photography to help you in these patients. You can follow retinal lesions, but you do have to watch out for artifacts. This is just highlighting a kid who has a small pupil who was treated with chronic anterior uveitis. Once you get a wide field photo here, you can see the acute retinal necrosis that's occurring in this patient. And this, just last week, I had one of my cornea colleagues just say, hey, I had somebody who came in with just some flashes. Would you mind just looking at this fundus photo I got? Because I didn't really know what was going on. I was like, great, can we call the patient back into the office because they have a detachment that you missed here superior nasally. So it's not just for uveitis. It can be used for other disease states. And some of our colleagues who are not used to a fundus exam, it can be a great way to follow some patients. I'm going to show you this last case just to highlight the last point I want to make out when you should over-image. So this is a 27-year-old female with a history of POHS, presumed ocular histoplasmosis syndrome, and was diagnosed with a choroidal neovascular membrane and was told there was nothing to do. Unfortunately, when you look at this patient and you see these lesions, she's had a drop in her vision. The fluorescein highlights not only the left eye that's involved, but the right eye that's also involved. The ICG tells you that there are choroidal lesions very clearly in the left eye. And the OCT shows you the variety of different lesions here. Subretinal, there is subretinal hyperreflective material. There's like these transmission defects that you can see as well. The choroid looks a little thick. The fundus autofluorescence highlights the whole thing for us. We have someone who has a significant disease that's going on here, and it's not just regulated to one part of the retina. This is multifocal choroiditis. This is someone who I immune suppress and actually does great and gets some great vision back. I never gave him an injection in the eye, never gave him anti-VEGF. This was all inflammatory. And so why I showed this case is what this taught me about inflammatory CNV is that sometimes it's easy and clear. Here's a patient who has intraretinal fluid, subretinal hyperreflective material on the left, gets an anti-VEGF and does great with improvement. So this was clearly CNV. But that same patient then comes back a year later and we think they still have some activity. They get an intravitreal Avastin injection and really no improvement. And it's not until you get an intravitreal steroid in this patient that we see actually improvement in some of these patients. So does that mean it was inflammatory? Does that mean it was a neovascular membrane? Sometimes it's not very easy to tell the difference. And you have to use your other tests like photos to actually show you that you have choroidal lesions. This is that same patient over a year. You can see the increase in choroidal lesions. So my point here is in these patients, when you have white dots and inflammatory CNVs, to over-image, check and recheck fluorescein, fundus autofluorescence in photos. Outer retinal lesions with loss of EZ and ELM, I want you to consider that this could be inflammatory. Think about starting them on oral steroids. If you have choroidal thickening, that's another clue to me that this is probably inflammatory. When you have increased transmission, that one's a little hard for me. Sometimes it is inflammatory, sometimes it's actually neovascular. Clearly when they have intraretinal fluid and subretinal fluid, it's more likely choroidal neovascular membrane. That's where my talk actually ended, so I'm actually not over that much. I'm going to end here and just tell you that multimodal imaging and uveitis can help you with lots of different diseases and to consider it in these specific scenarios that we talked about. Thank you very much.
Great talks, Sunil. It's my pleasure to introduce our next speaker, Ted Lang from Stanford University, who's going to be speaking on implementation of diabetic retinopathy screening program using AI. Ted.
Thank you so much to the organizers for having me here today. Continuing the potpourri of the session of different topics, we're going to be talking about how to implement a diabetic screening program during a pandemic. We'll be talking about some products from Digital Diagnostics that have no financial relationships to that company. But before we get started, I have to acknowledge the vast number of people that were involved over a multidisciplinary project like this, including some of my partners at Stanford, Dave Myung and Vinu Mahajan, and Darius Mashfegi, who we all know well, provided some cameras that we used in the initial pilot phases. Prithvi Murthrunjaya and Diane Doe, who are on the quality team of our department, as well as colleagues in the endocrine department and University Healthcare Allowance. So when we get right down to it, what are we're trying to do here? Well, we're trying to preserve vision by identifying diabetic retinopathy before it becomes problematic and intervening. We have these wonderful screening guidelines that the Academy provides through the preferred practice patterns that stipulate the frequency for which we do exams, usually annually after the first one. But this leads to many patients showing up in our clinics, getting an eye exam, very busy clinics that have no DR or mild DR that's not actionable when people who have severe disease or vision-threatening disease can't get in. They come in months later. We know that the treatments we have are quite effective. We have these great studies for PDR, DRS Protocol S showing the efficacy of the available treatments, and the anti-VEGFs and DME are quite effective as well. So what's the problem we're trying to address? Well, diabetic retinopathy is the #1 cause of blindness in the working age population in this country. We have 60,000 people in the U.S. who go blind annually from diabetic retinopathy, 30 million plus patients in America with diabetes, as well as another 50 million or so with pre-diabetes, and about 4.2 million of them have diabetic retinopathy. The current standard of care, which I mentioned, is an annual fundus dilated examination, but due to poor access, patient compliance issues, insurance issues, the compliance with this annual screening is very low, sometimes 15 to 50%, which is quite dismal. And the key preventative measures here is preventing the formation of DR in the first place, or the prevention of progression through early glucose control measures, as well as detection of early disease and treatment. So we've all heard about HEDIS. What is HEDIS? It's the Healthcare Effectiveness Data Information Set, now used by over 90% of U.S. health plans to measure the care and the quality of our service we provide. By 2008, it was available for use by medical providers and practices. Over 190 million people, which is a little bit more than half the people in the United States, are enrolled in health plans that use HEDIS, and it's kept current through a process by the National Committee for Quality Assurance. In diabetes specifically, that you can see here all the different measures that they might look at a health system or a practice for compliance with HEDIS, but the one that we can control is this retinal eye examination done on an annual basis again. So our hypothesis is that adherence with the annual diabetic eye exam can be improved with remote screening and telemedicine. And the ideal solution would identify disease requiring in-person attention, while then at the same time reducing the MD, medical assistant, and other resources by increasing throughput and only getting the patients that need care into the clinic. Artificial intelligence can help address these issues, and fortunately, in July 2020, AI exams were included in the HEDIS measures, and just this year, in January, a CPT code specific for autonomous AI went into effect. So phase 1 of our workflow is, you can see the little stars in our network here in the Bay Area. We partnered, again, with primary care and endocrine, and this was created using a traditional kind of store and forward mechanism where we place the center view cameras that Darius donated in these various primary care clinics, and then we had it linked to our PAC system. We use a Zeiss form system at Stanford, and those images were then sent to me and Vinu Mahajan, where we read the images and had a integrated Epic workflow where the reports would go back to the physicians and the patients, and we would recommend referral into a ophthalmologist if we detected actionable disease. In the pilot phase, which spanned the beginning of the pandemic in 2020, we saw 772 patients come through the program who opted for the remote screening. We gave patients the option in the primary care clinics to skip the additional visit to the eye care provider. We had about 9.5% of them that had mild or worse DR that we found. And despite the delays due to COVID, we increased the rate of diabetic eye examination in our population from 57.5% to about 70% across the 5 sites after we implemented this, which was actually the goal given the quality improvement metrics that we were presented with. So in this phase 1, we were able to demonstrate that we were able to implement the teleophthalmology program to increase patient adherence with this IBEG screening process and increase the HEDIS measures. So here we phase in AI. Here's a workflow again where the patients would get photos taken in the primary care clinics. The images are then submitted to the computer client The algorithm analyzes the images for diabetic retinopathy, and then a determination is made whether the patient had more than mild DR or not, and this device was FDA cleared in 2018. Here's a sample report of what we get. Again, positive or negative for the more than mild DR, or if the exam was of insufficient quality. We also integrated this report into our EHR for easy retrieval and also into our PAC system for future review. A more in-depth detailed look of how the algorithm works, there's actually first a quality assessment that's performed to make sure the images are actually gradable. You don't want a determination made on images that are not actionable or going to give you accurate data. And then it goes through a biomarker detection algorithm using convolutional neural networks to look for hemorrhages and microaneurysms, exudates, and so forth. So again, the partnership is key in making one of these things succeed. We spoke with the clinics themselves. We integrated the reports into Epic to make sure the workflow was as low lift as possible and frictionless. We visited the sites. You can see my partner Dave Myung here, who's a cornea specialist, but very passionate about this technology. Visiting the sites, training the staff there in conjunction with digital diagnostics. There was a slow delay as well because Stanford had a prohibition on on-site training during the early days of the pandemic, so we had to delay our launch until December of last year. But first, we were able to launch in December in Emeryville, which is close to Oakland, and we launched some sites on campus and in the south of the Bay Area as well, and you can see here the timeline there. And then we currently are having 7 sites that are using this autonomous AI. And you can see here the timeline. The blue bars are the actual number of exams by week. The dip there is the early days of the pandemic in April of 2020. And then the red line that's straight across is actually the goal to meet the HEDIS measure at Stanford University. And then the orange line that moves up is the actual percent of patients who have diabetes achieving that goal. So as we transition to AI, we are able to exceed the goals that we had set for ourselves. Well, I think in this pilot phase, we were able to show that we're able to implement a traditional human-in-the-loop diabetic retinopathy screening program, and then in phase 2, implement an AI workflow to complement that. But there's still a gap there. What happens when the AI is unable to grade an image? Because we're using non-mydriatic cameras, the NW400, and sometimes the patient has opacity issues, cataract, sometimes there's user issues, cooperability from the patient as well. So what happens? Well, we came up with a new plan now where we're going to bring the humans back into the loop to do what we're calling overreads. So this will reduce the reliance on AI, but still reduce the need for in-person visits in ophthalmology. And overall, hopefully improve patient and provider satisfaction. We want to make sure our partners in primary care are getting the service they want out from us for their patients and keeping them happy so they don't have to come in for an extra eye exam. So what are we doing now? Well, we have this original workflow, which I showed you, but if the image is ungradable by the AI, it gets kicked back out to me and Dr. Mahajan here, and then we read the images and then loop that back to the clinic. Here's some preliminary results just off the press from last month. You can see here the red bars are the kind of AI human hybrid showing the diagnosability of the images, and then as they started to shunt the ungradable images to the humans, me and Vinu, we were able to increase the success rate of actually grading the images, and we hope to get these up to 100%. They just haven't forwarded us all the images that were ungradable yet. So we're still working at, we're up to 80% of success in this teleophthalmology workflow. So a word towards reimbursement. I think one of the issues with in instilling any sort of teleophthalmology program is how do you make it a successful and viable business. Well, fortunately, we did mention earlier there is a code in January 2021 for autonomous AI, but there are other codes you can see here that do pay some work RVUs for the professional fee. And in conclusion, employing remote diabetic retinopathy screening was very, very important, especially in the face of the COVID pandemic, where patients didn't want to have any additional touch points with humans as much as possible. And I think partnering with primary care and endocrine was key in increasing our network and getting the reach. We did find that autonomous AI testing was useful for streamlining the care, and using our integration with the electronic health record was key in establishing this quality program. So thank you very much for your attention.
Great talk, Ted. Our next speaker is going to be Jaya Kumar from the Florida Retina Institute, who's going to be talking with us today on utilization of ultra-wide field imaging in diabetic retinopathy. Jaya.
Thank you. Grateful for the invitation to be here today, sharing the stage with so many of my mentors and esteemed colleagues, so thanks for having me. This is not the first, nor will this be the last talk that you hear on this topic. There's still so much information that we're uncovering about the importance, the role of diagnosis and therapeutic role of ultra-wide field imaging in diabetic retinopathy. Our goals today, our objectives, are to compare traditional 7-field system with ultra-wide field imaging in assessing the severity of diabetic retinopathy, correlating peripheral lesions on angiography with severity of disease, discuss some of the quantitative assessment of angiographic metrics, and finally, review some real-world cases that come into our clinics. So what is the definition of ultra-wide field? According to DRCR, it was defined as field of view of an image being at least 100 degrees or more. The International Wide Field Imaging Study Group defined using anatomical landmarks, saying it involved the retina up to and including the vortex vein ampulla in all 4 quadrants obtained in one single capture. So this is just an image showing you side by side, a handheld camera, the traditional photo, and then a more wide field image to just show you an appreciation of how much more of the periphery you can see. The 2 main wide field imaging platforms that are available are the Optos and Claris. The Optos is a scanning laser ophthalmoscope which can image up to 200 degrees of the retina in non-dilated eyes. This is more than 3 times the retinal surface area compared to the traditional ETDRS 7-field photos, which is illustrated in the image here, outlined in the white. You can see in the periphery where the arrow is that there is retinal neovascularization outside this imaging area. The Claris 500 and 700 are becoming more popular for their technology for true color images, which may help in assessing more accurate peripheral lesions compared to some of the other wide field imaging. The importance of the periphery wide field publications is really highlighted in this slide, and you can see this number, this graph showing an exponential increase in the number of publications since the technology began in 2005. So let's talk about how do standard photography and ultra-wide field imaging compare. So when we look at grading the images, the number of ungradable images with the ultra-wide field images was actually lower compared to the 7-field photography, and the amount of time that was required to actually grade the wide field images was quicker. At single center studies looking at grading and agreeability, there was actually an excellent substantial agreement between the two of 84% and within one level of 91% when evaluating the images, and it was much quicker to take the ultra-wide field imaging compared to the laborious 7-field images. This is a very interesting study that specifically looked at the distribution of where the diabetic retinal lesions were. So as you can see highlighted on the orange bars, the microaneurysm, venous beading, ERMA, neovascularization elsewhere were predominantly within the posterior pole within the 7-field images. However, if you look at the blue column, you can see that there's a big proportion, there's 34% of the neovascularization, for example, outside of this area. This suggested that peripheral lesions may have had a more severe retinopathy severity in 10% of eyes. Moreover, eyes with predominantly peripheral lesions had over a 3 times increased risk of progression of disease compared to eyes that did not have these peripheral lesions. Protocol AA by the DRCR further confirmed this. In fact, peripheral lesions existed in 41% of eyes, suggesting a worsening of severity of at least 2 or more steps in 11% of eyes. And for the post-test question, diabetic retinopathy severity, photos and imaging matched exactly in 59%. So we know now by looking at the images and looking at the data that these peripheral lesions matter. They do help in looking at the severity of disease and progression of disease. But now let's talk a little bit about quantifying. This is a 64-year-old gentleman that came into my office with, you can see, proliferative diabetic changes. There's vitreous hemorrhage. When we look at the angiogram, you can see posterior pole, there's quite a bit of neovascularization. But if you look in the periphery, you can see leakage and extensive peripheral, you can see extensive ischemia in the periphery. So what do we do with this? Like, how do we quantify the retinal ischemia? How do we quantify the microaneurysms? What do we do with that information? How does it help us with prognosis and treatment? Well, several of our panelists were involved in this study, investigating the relationship of the diabetic retinopathy severity and quantitative angiographic metrics. So they looked at 339 eyes and found that pan-retinal leakage index, the ischemic index, pan-retinal microaneurysm count strongly associated with the retinopathy severity. A significant proportion of eyes had anterior or pan-retinal findings, again, highlighting the importance of the ultra-wide field imaging. This image really nicely shows in 3 rows. If you the top one highlighted in purple, you can see the areas of retinal ischemia. Sorry, can you go back a slide, please? The middle column shows the counts of the microaneurysms, and the bottom row highlighted the areas of leakage. In this study, we looked at pan-retinal ischemia and macular edema. This was done in England, and the authors found that eyes with retinal ischemia were more than 3.5 times more likely to have diabetic macular edema than those without retinal ischemia. Another study specifically looked at recalcitrant DME, so eyes that had DME for over 2 years, and found that the larger areas of retinal non-perfusion and the greater severity of diabetic retinopathy had more recalcitrant DME, suggesting that there are some biochemical mediators promoting ischemia and recalcitrant DME. You know, Sunil already talked about this a little bit, but it's really important to look at the autofluorescence. We often focus on the fundus photo and the angiogram, but you can get a lot of information. This is a 31-year-old type 1 diabetic, never saw an ophthalmologist, came into my office, and you can see extensive neovascularization in the periphery there in the right eye and the left eye. After one anti-VEGF, you can start to see that neovascularization starting to shrink. You know, it's a very valuable tool to look at for us, but also for the patient. It really highlights what's going on and helps them with just understanding their disease. And Sunil also talked about this, that if you don't have venous access, you can try oral fluorescein, which actually worked quite well in this patient. 14-year-old girl with sickle cell in the periphery. There is some non-perfusion that was nicely highlighted, even though we couldn't get venous access. So we talked about a lot of the good things about ultra-wide field. What are the limitations? Well, the number one is the cost. So most people here are in academics, medicine. I'm in private practice. And I can tell you that we actually have an Optos in all of our offices now. But if you were a solo practitioner and had multiple offices, you have to think about whether it's cost effective. It's not portable. You can't take it from one office to another. Does require some training for your technicians as well as your photographers. I intentionally put this photo here to show the, sorry, can you go back a slide, please? You can see the eyelashes here are black string artifacts. So you really have to teach your technicians to retrieve. So how does ultra-wide field apply to clinical practice? Our conventional thinking of diabetic retinopathy, the grading, the staging, and ultimately therapy is changing. There are new insights on treatment selection, planning, and outcomes. And so in my clinical practice, I do find that it does improve clinical efficiency. If you know what you're getting into before you go in the room, review the imaging, look specifically at areas that are suspicious. This was already mentioned about eyes that have small pupils in children. And I'll tell you, during COVID, with our masks, we often have very fuzzy views of the periphery. So all of these reasons really help us in making sure we're making an accurate diagnosis. I use the imaging to really help teach my patients what's going on. And sometimes that's the motivation they need to start making a change and to start actually working on their diabetes control. I believe that there's going to be new data to help us answer questions on how often should we be getting ultra-wide field angiographies. If patients have more peripheral lesions and they're non-proliferative changes, for example, should we be following them up more closely? Future directions, which was nicely, Ted just nicely went over, integrating this in telemedicine platforms, integrating it into EMR, And hopefully we can use it in capturing, storing, and annotating and sharing images, which he just covered, which is great. So in conclusion, ultra-wide field imaging is a fantastic technology. We can obtain 80% of the retinal surface imaging in a quarter second. Clinically, we're visualizing the retinal periphery, which is providing important information in detection and management of diabetic retinopathy. And from a research standpoint, we're understanding disease mechanisms by looking at how do those peripheral lesions help correlate with progression of retinopathy and for recalcitrant DME. So I thank you for your attention, and on behalf of all of my 14 partners, or 13, I'm number 14, and in Orlando, thanks for having me.
Jaya, excellent talk. We're going to move on to the panel discussion now that Sunil is going to lead, but we also now have opportunities for questions as well from the room or from our virtual audience.
As we're waiting for questions, I actually have a question for Ted, if you don't mind. What you guys are working on at Stanford is really intriguing and exciting. Tell me, there's one part on your equation here, it gets referred to an eye care professional. This to me is, I think, the hardest part, I think, is time. Do you guys have the bandwidth? Like, I mean, you know, if you screen all these patients, what's the next step? I mean, how easy is it, or have you guys looked at, once somebody screens positive, to get these patients into clinic? And is it any eye care professional? You were talking about, like, reducing the number of visits. Have you figured out who should see, like, a general ophthalmologist or who should see a retina specialist? I'm just curious your thoughts on that.
I think everyone's situation is different, but we've been fortunate in that we did have the bandwidth up until this past year to absorb all these extra patients. We lost one of our partners to Jaya's practice in Florida.
So, thanks, Jaya. Nice job.
Yeah, thanks. So I used to have a next available appointment tomorrow, and now it's about a month away. And the retina specialists were the ones taking these patients in for screening. That's just the way we did it at Stanford. But like I said, everyone's practice is different.
Jaya, have you been using this in your practice? So you're using wide field as your screening tool for, like, patients, and were you replacing your diabetic screening in your offices with just with wide field photography?
Good question. So I guess I'll talk a little bit more about how we did teleretinal imaging in my second talk. But yes, during the pandemic, when we wanted to have fewer patients in our clinic, we would bring them in for wide field imaging, and then we would do kind of a telehealth visit with them afterward.
Glenn Jaffe has a question.
This is for Ted, actually. I noticed that there was a pretty high rate of additional input from you and your partner for reviewing the AI that didn't seem so accurate. And it's kind of a related question to Sunil's about the bandwidth. I was just wondering, how much work is this generating for you outside of your regular clinic to manage those AI failures?
It's still quite manageable. It's literally a handful a day, maybe 1 to 5 images per day I'll have to look at in addition to my regular clinic load. But of course, as it scales, we'll have to see how that turns out. But I think getting the workflow integrated well with the IT folks at your institution or your practice is key. I work with them very carefully to make sure I had the right smart phrase for Epic, and any sort of clicks I would have to make to drop charges that were appropriate were all as seamless as possible.
And just one for Jaya. You were talking about the 7-field versus the ultra-wide field, and it's been my observation that from a reading center perspective, the technicians in general are not very well trained to do either fluoresceins or fundus photographs, and 7-field is really difficult for them. But the one thing that we found that works quite well is 4-wide imaging. If they can do 50-degree images, and it's a very simple above the fovea, below the fovea, and nasal to the fovea, they can do that quite well. And I'm wondering if you've seen any kind of comparisons between that and ultra-wide field, because at least in the clinic, that's one thing that's fairly doable.
That's a great question. I have not, actually. I didn't come. Most of the imaging is comparing it to the traditional 7-field photos.
You know, along the lines of the 7-field versus the wide field, I mean, from an angiography standpoint, for me, there's no comparison. But when you look at the subtleties of some of the diabetic retinopathy findings, I've found at times the ultra-wide field can underestimate some of the more subtle lesions. I don't know if you found that as well, Jaya, when you look at it clinically versus that, whereas angiography often brings things out that you weren't expecting.
All the time. That's actually why I pointed out that autofluorescence is because I think there's a lot of new technology with the Opto software and helping with that green artifact, helping the colors to be more accurate. But I find when you look at the black and white of the autofluorescence and the angiogram, you can see so much more that's hiding.
Yeah. Could I just ask a logistics question to both Sunil and to Jay? You guys both mentioned oral fluorescein. And depending on the state that you practice and the requirements for who can actually inject fluorescein, it can be a logistics challenge depending on being out in regional offices. How do you guys do it in your offices? You know, what percentage do you feel like you get good results on that?
With oral?
Oral, yeah.
So I actually have a lot of adults that will do it too, because we have our diabetic population, as with everyone, are tough. Their venous access is difficult. So I would say I've had at least, I can think of in the past year, maybe 8 or 10 adults actually drink the fluorescein and do it. We don't get a good transit time, so I don't do it if I'm looking for an artery or vein occlusion, for example. If I'm looking more for diabetic retinopathy or uveitis, I will do it. We just mix it with like Capri Sun or whatever juice we have in our office.
Orange soda for us. That's what we
Orange
use.
soda.
Orange soda.
We have
is
Capri Sun. Yeah.
And I sneak it into the clinic because you're not allowed to have any
was
sweet
gonna say
drinks.
sugar.
Yeah, no, I have a pack of Sunkist that I keep for my patients. Let me ask you. We're talking about fundus photography. I'm going to ask Kat. I'm going to ask David this. Is fundus photography really what we should be using for these patients? I mean, is OCTA the better technology to screen these patients? I mean, some of these images that Kat showed on some of these diabetics, I mean, you're going to get this image of perfusion and maybe some of these other things really quickly without having to do it. So I'm curious, is the future really screening with OCTA?
Well, I think and I think that Catherine showed some OCTAs where the wide field is increasing every year from 3x3 to 6x6, 9x9, 12x12, and I'm sure we'll go even further. So yeah, as soon as we can get as far out to the periphery as we do with an Optos image, which should be within a couple of years, I think that will be additional important sensitivity that we will have in terms of detecting ischemia. We've already shown, many studies have shown, that you can detect changes with OCTA even in patients without diabetic retinopathy. So it's just a matter of getting out far enough into the periphery.
Yeah, I think that's a really good point. I think the only sort of caveat that I would have is, I would just have to feel pretty comfortable with being able to see if there's any neovascularization on those patients, because I feel like that's where wide field imaging is really helpful for me in diabetic patients, especially people who have sort of bland looking peripheries, but when you do the FA and you're just really struck by how much non-perfusion there is.
Ted, let me ask you, you've implemented this screening program. It makes a ton of sense. Practically speaking, do you think that the AI-based technology is the way we should go, or because it's not wide field, correct? It's a standard 7 photography, correct?
It's actually it's a 2-field.
2-field, sorry. And so do you think that's practically speaking the way to go, or should we be implementing non-mid wide field cameras to do screening? I mean, you're living in this right now. What do you think is the future here?
Well, I think the future will be the wide field imaging, but I think one point I want to make on the last question, I think cost is always an issue, right?
Yeah.
So you're talking, the average primary care clinic is a 2 to 4 physician practice, so they're not going to drop 80 grand on a camera.
Right.
So
unless someone's giving it away, Darius or someone is like, yeah.
We all need a Darius in our lives.
Right.
For many
Okay.
reasons. But yeah, but I think cost is going to.
We can quote that. We all need a Darius in our lives. Go ahead. I'm sorry. Finish your thought. I apologize.
I was going to say, I think, the costs will come down over time, I think, especially with these autonomous OCT devices, and I think that'll definitely be the future. And looking for the, if you use the vitreous slab, you'll be able to pick up NV quite easily.
Yeah, I wanted to show that on this patient. So I'm curious, and before you see your diabetic retinopathy patient, I'm going to give you this scenario. So Jaya, tell me, this is the patient, you get this history. Are you getting the fundus photo even before you see the patient? You kind of alluded to it, so you're not even, are you getting the wide field photo before you even see them?
Yes.
Okay.
The way our clinic flow is, we get an OCT fundus photo on new patients, and then we see them.
Gotcha. So this is the patient. That's their fundus photo in the right eye. I'm going to highlight, just give you a little bit more information. There's kind of no trick here. You saw some laser here. You can make out that there is at least severe in this patient. And the left eye here, I'm going to highlight a little bit more here. It's not clear at this point that there's neovascularization, but when you get the fluorescein, I think the fluorescein shows it really, really nicely the burden of diabetic retinopathy in this patient in the right eye and the left eye. So based on the color photo and the fluorescein leakage, I think the FA shows NV and looks like there's old laser. What I just wanted to highlight was here's the OCTA in this same patient, and that's the right eye. Kat showed this image, I think, previously, but this is the left eye, which I thought was great because I think you can see really nicely the NVD really well, and again, relatively quickly on an OCTA. So I'm like you, I get a fundus photo and I get an OCT, and I'm wondering more and more whether or not I should get an OCTA on these patients, since they're going to be in the OCT, anyway, just to give me an idea if I can pick some of this stuff out. So is that everyone's practice now? I mean, should we be talking about, what's the ideal modality? Is it for everybody the same? Do you think it's going to be like an OCT, a fundus photo in an optometrist's office or a non-ophthalmologist's office? Should it be an OCTA in other offices? So Glenn, you do a lot of reading center stuff. What's your opinion on what's the ideal modality here?
Well, at least at this point in time, I'd say the answer is no on OCTA, only because the rate of poor quality image is a lot higher than you'd think. So even in a diabetic retinopathy study, and even worse in a neovascular AMD study, and in a clinical trial where you're supposed to have certified technicians or photographers obtaining the images, the gradability is about 60%. And if you then put that in a general clinic where people aren't participating in trials, they haven't been certified, it's going to be even lower than that. So you showed a very nice image, but I would venture to guess that the vast majority of people across the country are not going to be getting images that nice that often. And so you're going to get a lot of artifacts. And I think once wide field OCTA gets better, you're going to need faster scanners and different algorithms to actually get far into the periphery accurately. Then I think it might be worth.
Well, I'm glad you like the image. I took that myself, so it means I could be a technician if I needed
We'll
to.
certify you with the
That's great. Kat, in your offices, you were mentioning this about the quality of OCTAs. What's better in your office? Is the Fundus Photography better quality or the OCTA better quality?
I mean, the really nice thing about using something like an Optos is you don't need to be an amazing photographer to get very good images. So, I mean, I think that's the one in my experience that really gets you the best images without you needing to sort of rely as much on their sort of expertise or overseeing them.
Excellent. I'm gonna end with one last quote because David said this way in the beginning and he snuck it in. Do you not get fluoresceins anymore?
In AMD patients, no.
AMD patients, so OCTAs only, no fluoresceins.
Only OCTAs for AMD. If I want to detect choroidal neovascularization, or what we refer to as macular neovascularization, I'll get an OCTA. In diabetics or inflammatory disease, certainly I think Optos FA and even ICGA is something I'll use in AMD patients for polypoidal. If polyps are better detected with ICGA than even OCTA. So it really is disease-driven. But in retinal vascular disease, yes, Optos FA is still important.
Okay, I was worried there for a second. There was no fluoresceins happening.
Don't throw it
All
out.
right.
Don't throw it out.
All right, we're going to end on that comment, and we're going to take a break. We're staying on time for our virtual world and in the real life. We're going to come back in 20 minutes and start back with new technologies and techniques in imaging. Thank you very much.
Last session. Kat Talcott has decided to come back and is going to talk to us about innovations in surgical imaging.
I think my job today is just starting these sessions and waiting for people to come in.
Exactly. We're just having you start because everyone likes your voice and your talks. That's why.
I think that's a sign that you're the junior person as well.
Yes.
Here are my disclosures. So there's been a lot of advancements in surgical technology, including the size of our cutters and the size of our instruments, but there's been less innovation really in terms of surgical imaging, really from the standard operating microscope. Fortunately, 3D heads-up display is an exciting technology that provides a digital stereoscopic view of the surgical field on a high-definition monitor and really sort of helps with the innovation of imaging. It helps to free the surgeon from the confines of the microscope eyepieces and may offer benefits in terms of ergonomics and efficiency. This is some work that I did when I was a fellow at Wills, where we looked at about 40 patients who had epiretinal membranes or macular holes in order to compare the standard operating microscope to 3D heads-up display to be able to sort of see how surgeons felt about them. And we found that 3D heads-up display overall needed less endoillumination, so better in terms of safety, but ease of use or comfort and peel time in terms of efficiency was actually better with the standard operating microscope. So this illustrates that there's lots of benefits to 3D heads-up display, but there's also potential room for improvement still with this technology. Another exciting surgical innovation in terms of imaging is intraoperative OCT, which is well beloved by us at Cole, which is a valuable surgical adjuvant to ophthalmic surgery that increases our understanding of the pathophysiology of surgical disease and helps to provide really real-time feedback to us who are operating. Here are some examples of the utility of intraoperative OCT. This is a case of a membrane peel where real-time OCT can show traction that's exerted on the retina while you're peeling an epiretinal membrane and ILM. Another example where it can be really useful is in terms of subretinal injection of TPA, where you confirm that the cannula is underneath the retina but above the RPE before you actually inject TPA. Intraoperative OCT can even be helpful when you're looking at things outside of the eye, such as in this case of scleral windows for uveal effusion syndrome, where you can see the depth of the scleral window that you're making and to confirm that a small sclerotomy was actually made. So intraoperative OCT can provide surgeons with additional information on sort of subtle changes in the retina and also tell us information about how it's responding to the maneuvers that we're doing. It can help guide us to do procedures when they're necessary, but also helping to tell us when you're done as a surgeon. So intraoperative OCT can lead to sort of safer and more efficient surgery with improved outcomes. But we were sort of wondering, how do you best integrate these two things together? And this is some work that we've done at Cole as part of the Discover study. The 3-year results of the prospective Discover study showed that there was a strong surgeon preference for visualizing the OCT on a 2-dimensional screen that actually requires you to look away from the surgical field as compared to using OCT data that's injected into the microscope oculars. So based on this, and that in part might be due to small visualization of details on the intraoperative OCT when you're actually looking into the oculars. So based on this, we wondered if there was a way to sort of integrate this technology together better. We recently published on this about where you can integrate intraoperative OCT to the surgical screen in terms of using 3D heads-up display. And we wanted to examine this a little bit more. So we compared surgeon experience in between conventional microscope integrated intraoperative OCT and digitally enabled intraoperative OCT as part of the Discover study. So this was a sub-analysis comparing conventional intraoperative OCT to digitally enabled intraoperative OCT. And you could review the intraoperative OCT by looking at the surgical field or by looking away to the monitor of the microscope. And we compared how useful it was, how efficient we were in terms of ergonomics feedback as well. And this was done by using a standardized questionnaire. So we enrolled approximately 180 patients, and baseline characteristics were pretty similar in between the two groups. And of note, the most common surgical indication was epiretinal membranes followed by macular holes in this case. There were no surgical complications that were attributed to the intraoperative OCT, and complications were similar between the two groups. So overall, interestingly, we found that surgical field-based intraoperative OCT visualization, which was much higher in the digitally enabled group as compared to the conventional group. And this might in part be due to the way that things are arranged in terms of the operating room. As you can see on the left, in terms of the surgical-based visualization of intraoperative OCT, you can see that both the surgeon and assistant can just continue to look forward, but if you're actually looking at screen-based visualization, both the surgeon and the assistant need to look away from the eye and around the microscope in order to be able to see better what's going on. In terms of ergonomics, we found that there was a higher rate of back discomfort and headache in the conventional intraoperative OCT group. But overall, in terms of the intraoperative experience, it was pretty similar between the two groups, save for in the digitally enabled group, there was more likely to be, the macular view was considered to be excellent. So there's some limitations to this study. Part of it is due to probably the assistant versus the surgeon. So the attending for these cases at our teaching institution were the ones that filled out the survey, but their position as being the surgeon or assistant differed, and that could and that could compare how comfortable they were. And this was a non-randomized study, but everyone who was included in the study must have had cases in both groups. So what's next in terms of this? This is an example of sort of using even more integration of information into the digital screen. You can see the real-time OCT screens, but you can also see input from your constellation as well to be able to give you more information about what the pressure is doing and the vacuum and the cut rate, which can really lead to sort of a true integrative experience. And this is an example of doing a TRD, where I find it's really helpful to get all this information. You can see with the intraoperative OCT, you can see sort of where the planes are when you're deciding where you can sort of pull off fibrovascular tissue and sort of get more information. I think it's also really helpful for these cases because you can keep a sense of where your pressure's at. You can see that I'm on sort of 60 now, as well as to be able to get real-time information about sort of where planes are. So that can be really helpful. Another exciting advancement is the Artivo system by Zeiss, which is the first 3D capable digital ophthalmic microscope. I don't know if anyone else has had a chance to use it, but it's really great. It offers a hybrid mode that allows a surgeon to be able to view the surgical field by using 3D imaging on the screen or through the ocular, so it gives you some flexibility. And then the 3D images are on your 55-inch screen, and it's equipped with intraoperative OCT as well. So it may offer improvements in terms of latency. Surgical field color is a little bit more accurate than using the Ingenuity. It might also lead us to need less end illumination and make it a little easier to use the intraoperative OCT. So here's an example of an Artivo case of doing peel, and you can see how great the OCT image is as we're sort of peeling, and you can see the sort of instrument and sort of all the traction that's, or lack thereof, on the retina. And then one last innovation that is also, I think, really exciting is head-mounted surgical visualization by the Bionics One group, which is a camera head unit that comprises of 3D ultra-high-resolution cameras, stereoscopic eminent illumination system, and a removable mount. And so the user interface for this system really combines operation of the foot switch with head gesture commands and really allows you to integrate intraoperative OCT. I haven't had a chance to use the system, but I think it's really exciting. So in conclusion, intraoperative OCT integration with 3D surgical visualization is feasible. The large screen-based visualization of the OCT data screen really allowed us, as far as we found, to minimize the need for an accessory screen. And digitally enabled intraoperative OCT can provide improved ergonomics and increased attention on the surgical field during the OCT system. But we need more studies to better assess sort of how this affects patient outcomes, surgeon experience, and overall value of enhancing our surgical theater experience. So I want to thank my mentor, Justice Saylors, and our collaborators at Cole for their help.
Thanks, Kat. Justice Saylors, perfect timing, is going to talk to us next about next-generation machine learning enhanced retinal feature segmentation, unlocking the imaging phenotype. Justice.
Thanks, Sunil, and thank you, Kat, for giving me the extra minute. I really appreciate that.
You will use it very well.
So these are my financial disclosures. So as we all know, as really why we're here today, is that retina care is an imaging-driven specialty. And when we look at the field of retina, it includes some of the most common blinding disorders, including macular degeneration and diabetic eye disease. And imaging for all of us is really ubiquitous in how we manage and make clinical decision-makings on a day-to-day basis. And we're also hampered by the challenges of the high daily patient volumes and diagnostic testing burden and interpretation. Being able to integrate enhanced image analysis and AI-based technology, as we've already heard in many of the talks earlier today, could potentially augment treatment decision-making and personalized care. So when I look at this and I think about what's our current clinical phenotype and the way that we make decisions about patients, well, we look at the clinical characteristics, we look at their visual acuity, and we examine them. And then we get all of the imaging that we do. It could be fundus photography, angiography, and OCT. And then based on that picture, we make a decision of what's the phenotype that we're seeing in front of us and what do we do next. More and more, we're relying on these specific technologies to make those decisions, as we heard in Sunil's talk around the uveitic side of things. And so from this, we take away that this patient has proliferative diabetic retinopathy with diabetic macular edema. We start with our anti-VEGF of choice. We try it for a while. We see how it works, and if they respond, and if we try and fail, we try something different. And it may be 6 months down the road before we find the exact right treatment or regimen that we need for this patient. When we think about precision medicine and retinal disease, it's really a ripe area for us to be able to looking at how we could advance technology here. Using next generation systems, really there's significant opportunities to more characterize an individual who's sitting in front of us to allow to predict disease behavior and precision decision making. There's extensive disease-specific and patient-specific information that's encoded within these diagnostic studies that we're really leaving on the table that we don't use when we do our standard interpretations. And harnessing this data-rich medium may enable advanced characterization of these specific features that allow critical insights into the disease process. So what is the imaging phenotype? We heard, again, a lot of this around different diseases that we see. Well, what if we had quantitative ultra-wide field angiography, enhanced ischemia assessment to give us a zero density index, compartmental radiomics to understand the texture implications of specific fluid, being able to understand the biologic pathway feature characterization of diabetic eye disease and what's driving a specific finding, outer retinal integrity assessment to better understand visual prognosis, as well as fluid feature extraction to understand overall disease burden and maybe what treatment may be best. And from this, in an imaginary world, maybe 3 or 4 years, 5 years down the road, maybe we could better understand disease that this is PDR with DME, characterized by high pan-retinal leakage index, moderate ischemia, subretinal fluid dominant, and outer retinal attenuation that is a VEGF dominant picture with IL-6 component. And we want to start intensive therapy with aflibercept, add perhaps a steroid component after that, and that this patient's going to have a really high response to that therapy that ultimately may be able to transition to a extended therapy. And when we look at this from a patient characterization and education standpoint, this can be huge when we're looking at how do we make decisions around treatment. So what are these next generation opportunities? We've heard a little bit about some of these already today. So quantitative ultra-wide field angiography may be a particular important opportunity in retinal vascular disease. We can look at this patient in our clinic and we say that this patient has a lot of leakage, some ischemia, some neovascularization, and that's about where we stop. We then move on to the next modality. But if we were able to characterize that at a quantitative level to understand how many microaneurysms are present, how much leakage is actually happening within the retina, and how much ischemia is present, we could better understand treatment response and potentially better understand treatment prognosis. So as we look at this and better evaluating these technologies, one question is, can we put these in clinical trials? We looked at this with angiography, and we see this was a patient who was actually in a study. This was their baseline angiogram, and after 6 months of monthly aflibercept treatment, we see just a dramatic response here. When we look at it more carefully, there's some subtle features that we may not pick up as readily clinically, including resolution of the microaneurysms that we can see here. And if we could actually count that, we could show that this patient went from 354 microaneurysms at baseline to 65 after treatment, as well as a dramatic reduction in leakage index from 25% to 3%. In addition, we could see that the ischemia didn't change, and so perhaps anti-VEGF therapy doesn't have a major impact on this modality. And we've looked at this in a recent trial with Charlie Wyckoff's group, where we've obtained monthly ultra-wide field angiograms and found that using the leakage index was a more sensitive indicator of potential worsening compared to DRSS scale when treating with anti-VEGF therapy. What about the vasculature? Well, we've seen these amazing pictures of OCT angiography, which holds a lot of promise as well. When we look at ultra-wide field, we now have technologies, and multiple groups have looked at this, to be able to use machine learning to extract vascular features, and to be able to look at this and measure quantitatively what's happening in terms of tortuosity, changes that we can't really pick out from a clinical standpoint that may have relevance in terms of how a patient may respond. Being able to quantify ischemia as well in different ways, including things like local vascular density assessment, as we can see here. When we look at radiomics, this is a new and emerging field that's initially was brought out in radiology. And this is one of my partners at Case Western, Dr. Anant Matabushi, has really made his career in radiomics in oncology as well as in cardiology. And what this field is looking at subvisual features within images that have biologic relevance. So for example, the texture of the intraretinal fluid within a DME cyst. Maybe it gives us an idea of the chronicity or the potential response to a therapy. The shape that we may see in terms of a leakage node in a specific disease. And so we started to look at this with some of our imaging modalities, and we looked at, for example, tortuosity features on ultra-wide field angiography. And we found that looking at this at baseline, we could actually identify differences in eyes that 6 months later could tolerate or not tolerate extended interval therapy with aflibercept for diabetic macular edema. We also started to look at this to see whether we could link this to aqueous cytokine expression, and found that there were specific unique radiomic features in the retinal periphery on ultra-wide field angiography that were more linked to VEGF overexpression compared to eyes that had lower expression. And again, this may be able to help us understand what specific targets we should be looking at as we get more and more therapeutics going down the road. What about OCT? Obviously, this is really the backbone of what we use on a day-to-day and patient-to-patient basis, and has transformed the way we look at retinal disease. But we're limited based on our current analysis platforms. We really kind of look overall at measuring the box, but not actually unpacking what's inside the box when we look at OCT. There's only limited correlation when we look at central subfield thickness to functional outcomes. But if we could actually start to look at this in specific areas of interest, we may be able to understand diseases in a better way. Looking at the outer retina is an area that's continuing to emerge in ways that we can look at, and multiple groups have assessed this in various ways, particularly because of its importance to functional outcomes in multiple different diseases. One of the things that we've looked at is how we can use machine learning-based augmentation for multi-retinal layer segmentation to be able to extract specific features of interest and compartments of interest in different diseases. One of the areas of particular interest, as we've heard earlier today, is dry macular degeneration, and specifically being able to look at ellipsoid zone integrity, the sub-RPE compartment, being able to understand drusen dynamics and geographic atrophy dynamics. And so we looked at this in a cohort at the Cleveland Clinic to specifically look at differences in eyes that progress to subfoveal geographic atrophy. And this was an eye at baseline who had moderate drusen burden, we can see here in the sub-RPE map, but the ellipsoid zone integrity, which would normally be green, overall looks quite good. This was another patient who had no signs of geographic atrophy at baseline, but significant loss of the ellipsoid zone that we can see here. And then 2 years later, we see what is almost moving into that area of ellipsoid zone loss, the new geographic atrophy lesion that we can see here. When we found our ability to classify this, we looked at multiple parameters in terms of including many of the qualitative biomarkers that have been shown to be important, but the quantitative features were really what dominated our ability to classify these eyes in a reliable fashion. When we look at this in terms of emerging therapeutics, we've had the opportunity to look at this in different small studies to understand, is there an opportunity here to better understand response to treatment? This was from the RECLAIM trial that was sponsored by Stealth, and what they were looking at was whether or not there was visual acuity improvements that were tied to ellipsoid zone integrity. And we see here at baseline a 2-letter gain when there's hardly any ellipsoid zone that's left, compared to an 18-letter gain in this eye here that we see was preserved central ellipsoid zone integrity. What about looking more at the pathology? We heard Rishi's talk this morning of being able to extract fluid and the potential importance of really understanding what's happening there. And we heard from David the differences in fluid and what we may see in terms of subretinal fluid characteristics and intraretinal fluid characteristics, and maybe using machine learning augmentation and other techniques that many groups have described, we may be able to better understand those fluid dynamics in ways that we can actually better understand disease prognosis and therapeutic targets. We now can actually pull this data out and actually look at this on a longitudinal basis. This was work we did with the phase 3 VISTA trial, where we're able to look at this in every patient and actually quantify their fluid dynamics over the entire portion of the study, as well as looks at ellipsoid zone integrity. What we found was that although central subfield thickness didn't correlate with functional outcomes, ellipsoid zone parameters had strong and robust correlation, as well as when we look specifically at central macular retinal fluid indices, as well as when we could pull that fluid out and look at the retinal tissue volumes without the presence of the fluid that was there. Looking at this as a biomarker, we could also see that retinal fluid volatility early on in treatment, even during the loading phase, was one of the biggest predictors of recurrence later on in treatment. And again, when we started to look at, can we link this to biologic biomarkers, we found that when we looked at specific spatial features within intraretinal fluid, for example, we could identify eyes that had a high VEGF expression compared to eyes that were appearing to go down a different pathway in terms of their DME manifestations. We also could then identify differences in eyes that responded well to extended therapy. So in the future, where are the opportunities and what are the needs? So I think there's a tremendous amount of opportunities, but there are clear challenges. How do we generalize this across diseases and across technologies that provide biologically relevant information? We want to be able to consistently extract this. One of the things we heard earlier is the importance of quality that Ted mentioned in terms of being able to reliably characterize this, and these are important features that we look at in clinical trials as well as our clinical practices. Within the field of retina, really almost every disease could potentially be characterized in a more advanced way to help us be more precise in the way we take care of our patients. And imaging biomarker discovery is, I think, one of the exciting areas that's emerging that we're seeing here as well. So I want to acknowledge my team and partners at the Cleveland Clinic. And again, thank you for your attention this afternoon.
Thanks, Justice. I think it's Rishi, David, sorry. I know, yeah, it's okay. You both can talk at the same time.
David,
but
why don't you
it's
just do the talk?
I want to remind everybody, if you do have a passport, to turn it in to our people at the desk so you can get yourself an opportunity for the door prize, which Rishi is going to sell on eBay or put on his Twitter account. Rishi, welcome back. You've had a busy day, sir. Thanks for coming and talking to us, investigating mitochondrial activity in retinal tissues.
Thank you. This is a work that we've been working on in the Cleveland Clinic for the past few years, and it's really great to see this kind of flourish and get more information from this the past couple of years. Here are my financial disclosures. So I'm going to talk about mitochondrial dysfunction and retinal pathology. I'll talk about some of the imaging technology we now have for mitochondrial dysfunction. I'll actually show you examples and information from our clinic on patients with diabetic retinopathy and AMD and show you how it's been able to stage patients. For background, mitochondria obviously provide 90% of the energy needed for oxidative phosphorylation, and you can imagine in situations of macular degeneration and diabetic retinopathy, there's stress on these cells, which leads to apoptosis. There's increase in superoxide dismutation and production, depolarization of the mitochondrial membranes, and reduced oxidative phosphorylation as part of these disease states. And the retina is a very highly metabolic tissue. It's mitochondrial dense, and it's a high susceptibility to suppressors like vascular compromise and dysfunction of the mitochondria, which actually can be genetic in the case of macular degeneration, but it can also be vascular in the sense of diabetic retinopathy. Here's actually a cytochrome C oxidase staining of the retina on the right side, which shows you where all the mitochondria are located. So you can see high densities with both the nerve fiber layer and the inner retinal layers, but also within the photoreceptors and the outer segments as well. This is sort of the thought process of what happens within those cells over time. And the mitochondria have these flavoproteins, and in particular, they're reduced when they're in a reduced environment, a good environment that's not pro-oxidative. With oxidative stress and damage, these become oxidative flavoproteins, and eventually they can be applied light barriers for excitation and emission. And if you give them an excitation light of 467 nanometers and an emission barrier of 535 nanometers, you actually get them to emit autofluorescence. And in this case, you can follow them in conditions like macular degeneration and diabetic retinopathy, but more in particular, glaucoma has been one that's been addressed, and it's being looked at by Rick Rosen in New York, and he's really spent a lot of the past couple of years looking at glaucoma patients and the nerve fiber layer damage that occurs with mitochondrial dysfunction. This is just some basic science work. Looked at human retinal pigment epithelial cells cultured in the lab and looked at cells treated with hydrogen peroxide, which causes apoptosis and increase in superoxide dismutation. And you can see higher levels of this flavoprotein fluorescence within those cells. And then you give it the antioxidants and apply also that hydrogen peroxide, and you see that those levels decrease as well. Ceramide is another product that actually can produce increases in oxidative phosphorylation and apoptosis as well. And we give it the dihydroceramide, then you get the reduction of the FPF, the levels within those cultured cells as well. Actually, we know that from tissue staining and EMs of patients with AMD that aging increases reactive oxygenase species, and you actually get damage to the cristae within these mitochondria. They become very plump looking and unfortunately lose a lot of their normal function. And they actually form those casts that you see, those GM areas where they actually are lost over time in patients with severe damage from AMD over time. And actually there's mitochondrial DNA variants which are associated with Druzanoid phenotypes, which can lead to those dysfunctions as well. So can we detect this mitochondrial function in vitro? And I think it's important just because there's a lot of different technologies out there that look sort of at fluorescence, and I'm going to talk about them just for a quick moment to show you them. Emission is an important function of some of these autofluorescent technologies because it's a wavelength of light that you give off. Clearly, in this case, we're looking for a specific wavelength versus autofluorescence, which may look at all wavelengths of light. There's intensity, which is the brightness of the return signal, and finally, lifetime fluorescence, which is the duration of the signal. And so here is actually those three technologies which are kind of out right now. Some of them are obviously very experimental at this point. FAF is obviously something we're all used to using. This measures both emission and intensity and looks for the cumulative fluorescence of all the fluorophores within the retina. But this FPF imaging actually looks at just specifically the FAD and the FMN mitochondrial flavin proteins in that case. And then you have FLEO, which is actually another technology that's been around for a little bit, really in experimental platforms. Again, Heidelberg has been in the forefront of developing this technology. This measures lifetime fluorescence, and it has a time of multiple fluorophores that decrease over time. I just want to show you this because I think it's important to show you that there's a lot of, obviously, wavelengths of autofluorescence which occur on the lower end of this curve, which we're looking at. And I'll show you why that's relevant in a moment. We have the lens fluorescence we have obviously fluorescein dye that we use, and those can all, and lipofuscin for that matter, and those can all cause autofluorescence in their own part, and so therefore need to be taken into account when we do this, evaluation. This is actually the way the camera looks. It's an IDON camera, so it takes an infrared image and then takes a FPF readout of the patient's image with the barrier and excitation filters. And the post-processing work is really where this technology has really developed in the past couple of years, because now we can take into account things like lens fluorescence, and even the IOLs we put in patients have their own natural fluorescent characteristics, and so we have to take that into account. And we've created algorithms now to actually subtract out those lens fluorescence and other activities as well. I think it's also important to talk about this intensity versus heterogeneity. And this is a concept that may not be familiar to you, but we can see that in two different patients, you can have equivalent numbers of areas under the curve, but you have two different peaks in the patient that has more heterogeneity versus a patient who has a single peak and has less heterogeneity. And here on the lower right corner in that blue, you can see those yellow specks, and that's actually the heterogeneity present in these patients. And this is an important concept because it shows you the differentiating points of the mitochondrial FPF scores that you get back, rather than just the true intensity. You see the heterogeneity can show you the diversity of the signaling in the patient over time. We found that this test is very repeatable. This is kind of the first test we had to do with a very good ability to repeat these tests and get the right numbers between patients who were tested in the same sitting. We did this in my clinic where we imaged patients over a 15-minute period and performed consecutive images and found a very low rate of variability. And we've looked at this as aging of the eye, and we know that aging obviously increases the FPF intensity on the left side, but also increases the FPF heterogeneity. So we have to take aging into account when we do these analyses, making sure we have age-matched populations when we do these studies as well. This is actually some of the work that we published last year in Eye, and it really shows, again, that the intensity changes in patients with levels of diabetic retinopathy didn't change very much. Actually, they weren't statistically different from each other than the patients who were controls versus those who had diabetics. But now you can see on the right side where the heterogeneity in those patients really is statistically different between those groups and can be actually measured as well. And when we looked at this actually in a predictive model for visual acuity at baseline, we found that FPF heterogeneity actually could predict about 13 letters of potential change in the patient's visual acuity depending on the readout that was given within that study. We've actually done some recent work actually in the AMD space as well, where we looked at a lot of patients now. We have over 800 patients we've enrolled in this study as well. And we found essentially that the heterogeneity increases as the disease state progresses. And you see on the far right side both advanced non-exidative geographic atrophy in these patients and even neovascular AMD having the highest levels of heterogeneity. And these were all statistically significant from each other, and we were able to show that we could differentiate these disease states based upon the heterogeneity measurements. This is actually another way to show this is kind of a box plot showing you, again, all of the patients. On the far left side, you see the control patients. On the far right side, you see all of those disease states as they progress through the AMD phases. And here, broken out a little bit more, you see how the neighborhood of early AMD differs from the intermediate AMD. And even if you look at the neovascular AMD patients, those differ far from the control patients. So now we have the ability to do all these sort of measurements. But can we really predict before there is structural damage to the OCT that the mitochondria are being affected? So let me just show you a quick case that kind of gives you maybe that example. This patient has neovascular AMD. They're undergoing treatment month to month. Their retinal thickness at visit 1 was 231 microns. They had the level of intensity and heterogeneity listed there, and they had visual acuity of 58 letters on the ETDRS chart. With the single injection of the anti-VEGF, you see that the levels of the FPF heterogeneity go down from 2.0 to 1.73. Their visual acuity obviously declines slightly, even though the retinal thickness is improving. And finally, on the last slide, you see that the actual ETDRS visual acuity improved while the retinal thickness sort of remained stable, only by 20, 30 microns. And so this was sort of our first attempt at looking at some of these patients. And we have a really rich data set now where we're looking through hundreds of patients, both before and after treatment, to see if this could predict visual acuity response better than the structural OCT could in our practices. And that's really where it might be an exciting technology to use. So in summary, mitochondrial dysfunction plays a role in common retinal pathologies. Flavoprotein fluorescence can be a proxy for mitochondrial dysfunction, both in vitro and in vivo. We know that heterogeneity has been shown to be useful in the detection of diabetic retinopathy stage and visual acuity. And our recent data actually validates its use in AMD phases as well. And I think our preliminary data is really interesting to look to see if we can actually determine response to anti-VEGF therapy. And I would just say that the paradigm for a lot of us in clinical practice is we wait till structural damage occurs. Well, you don't do that in normal practice for yourself, right? You change things in your home before the pipe leaks or has a problem. You don't wait till the pipe actually bursts within your home. You want to try to get these things addressed ahead of time. In this sort of state, maybe we're picking up the disease earlier before where there's metabolic dysfunction and not necessarily structural function early on. So maybe this is an opportunity for us to look at that as a marker rather than OCT, which is structural and shows maybe irreparable damage in those patients over time. So that's it.
Thank you, Rishi.
Thanks.
Don't take the prize yet.
Oh,
Bud. Now, Dr. David Seraf can come on back, and he's going to talk to us about epivascular glia. David.
All right. Thanks, Sunil. I'm going to talk about epivascular glia, or activated glial cells, from FUS to Kishi to on-FOS OCT. Here again, my disclosures. I want to acknowledge several of my fellows who've been involved with many of the experiments or projects that we've published relating to this talk. So it's an important concept that glia, such as Mueller cells, can activate through breaks in the ILM that can develop as a result of chronic vitreoretinal traction. This concept was actually first identified by Robert Fuss, who it turns out is a histopathologist at UCLA in the 70s. I remember actually seeing him working in the lab as a medical student in the 90s when I was doing some post-medical school work there. And what he was able to identify was Mueller cell proliferation through ILM breaks, that these Mueller cells or activated glial cells grow along the surface and interdigitate with epiretinal membranes that he was able to illustrate with transition electron microscopy. Kishi later on described the same concept using scanning electron microscopy, and that's when the term epivascular glia was coined. What we've been able to show with on-FOS OCT are these same morphological lesions that demonstrate the stellate hyperreflective plaques with dendriform processes very similar to what has been described by Kishi and Fuss, and we propose that this may be a precursor of epiretinal membrane formation. So this is kind of summary of what I'll talk about in this talk. So here are the original transition electron micrographs that Fuss published in the 70s, showing these glial cells growing along the surface of the retina through breaks in the ILM and interfacing with an epiretinal membrane. And he showed that they typically were present along the major arcades and around the disc where there was increased vitreoretinal traction. And you can appreciate these glial cells. They're breaking through the ILM and they're growing along the surface of the retina, and then, as I say, interfacing with this epiretinal membrane. And he attributed these to increased vitreoretinal traction, causing the breaks in the ILM and activating these glial cells. 10 years later, Kishi, using higher resolution scanning electron micrographs, was able to show the same thing, but the images were remarkable. They all have these stellate plaques with these fine dendriform extensions, and he coined the term epivascular glia as they grew along the surface of the retina, along the major arcades where there was increased vitreoretinal traction. And you can see these scanning electron micrographs are very impressive and have a very characteristic stellate morphology with these fine filamentous dendriform extensions that are characteristic of glia cells. He also described similar cells in the fovea, And he coined the term the white dot fovea, and you can see these lesions again, when magnified, have a similar morphology to the epivascular glia around the major arcades. We have availed ourselves with en-face OCT technology, especially in the era of OCT angiography, because OCT angiography provides a dense volume data set of B scans, and so we can reproduce the en-face OCTs with great facility. And what it does is it projects the B scans and the interrelationship of the binary reflectivity onto a coronal plane, and so that you can see the pattern of the hyper and hypofluorescent changes at a given segmentation plane. And this is just a cartoon that illustrates the concept of en-face OCT. And as I say, it can better illustrate the pattern of hyper and hypofluorescent lesions that you see in a single B scan, showing it over the entire fundus in the macula at a given depth resolve segmentation. So for this entity, en-face OCT was able to really illustrate and give us insight into what's going on. And you can see on the cross-sectional B scan, you have these little dots on the surface of the fovea that you probably have never even thought about, but you may see in many of your patients. When you look at these dots on an en-face OCT, you actually see a very characteristic array of these lesions in the fovea. And one of our fellows, Jaya Kumar from Italy, was able to look at these en-face images. She developed a segmentation strategy, binarized the lesions, thresholded them, and then quantified them in all our patients, and showed that these little white dots actually increase in number according to the decade of the patient's age. And here's on this screen, the top left is the youngest patient, the bottom right is the oldest, and as you get older and older, you can see an increased number in these dots that are aggregated in the fovea, these hyperreflective dots. And here another example showing the increased number of these dots on the B scan as well as the en-face OCT according to age. And when you magnify these lesions, again, they look very much like what Kishi described as the white dot fovea. And in this second paper that one of our residents published, he actually magnified the dots, measured them, and did some other interesting investigations, and showed that they very much look like the lesions that Kishi originally published. They have the stellate morphology, the fine dendriform filamentous extensions, and the size is very comparable to the white dot fovea lesions that Kishi described with transitional electron microscopy. Then we shifted our attention to the major arcades, and we found that similar lesions are present around the major arcades that also demonstrate this stellate appearance. And so we developed looked into the database, developing another segmentation strategy, this time by Christelle Grondel, one of our fellows out of France. And again, with special segmentation, binarization, and thresholding, we were able to isolate these lesions. And she went through our database of 2,500 eyes and identified all the patients who showed these characteristic stellate plaques along the major arcades that we referred to as epivascular glia. And she showed that they were present in 5 to 10% of our patients and were highly associated with patients who demonstrated a foveal PVD. So that means a grade 3 or 4 PVD, or PVD where there's detachment at the central foveal region, and that these epivascular glia were also associated with epiretinal membrane formation. And I'll show you some illustrations of what we were able to find. So the top panel includes the red squares, and then those areas are magnified in the bottom panel. And again, you can appreciate these stellate hyperreflective plaques all around the major arcades that again have the fine dendriform extensions, and in this case look very much like the epivascular glia that Kishi originally published. In fact, there's also a study by the Johns Hopkins group using retinal whole mount analysis, and they found similar lesions using histopathology as what Kishi found with scanning electron microscopy. And again, you can see the morphology and pattern looks very much to what was described with histopath and SCM by the Johns Hopkins group and the group in Japan. You can also see other associated changes of vitreoretinal traction. Paravascular holes or paravascular schisis is something you can pick up with en-face OCT. And here you can see a representative en-face OCT image showing the paravascular holes and the adjacent areas of epivascular glia in this patient, again, who probably has chronic vitreoretinal traction around the major vessels. And again, the representative images that I've already illustrated to you showing the typical morphology of epivascular glia with en-face OCT approaching that with that which we see with EM. It was also interesting that we could identify epiretinal membranes in association with these epivascular glia. If you look, the epiretinal membranes are typically more central with this radial array of hypo and hyperreflective stria. And what Christelle was able to do is map the epiretinal membranes in pink and the epivascular glia in red, track them sequentially in these 4 patients, and you can see that the epiretinal membranes in red originate from the epivascular glia closer to the arcades and migrate towards the center and then progressively contract and cause these radial array of folds that are more typical of epiretinal membranes. So in summary, glia can activate through ILM breaks in areas of increased vitreoretinal traction, such as in the fovea and around the arcades. This was originally described using transmission electron microscopy by Robert Fuss, and then also by Kishi using scanning electron microscopy. The morphology of these lesions look very similar to what we've been able to isolate with en-face OCT, in which you see a stellate plaque with dendriform filamentous processes, and we believe that these epivascular glia may be precursors of ERM formation. All right.
Thank you, David. You did the same thing, Justice. You're not paying attention. Jaya Kumar is going to come back and talk to us on telehealth-based retina care, lessons from the pandemic and future directions. Jaya.
Thank you. So our goals today are to review the benefit and limitations of telemedicine for eye care providers, talk about combining telemedicine with retinal imaging, evaluate the platforms that we have currently available for telehealth, and finally, look at where we're headed in the future for retina. So the concept of telemedicine was introduced to the American pop culture on the popular show in the 1960s on The Jetsons. For the next couple of decades, we watched Inspector Gadget be able to communicate with his sidekick Penny through his super fancy watch, which we all have now. And I remember 25 years ago going to Walt Disney World at Epcot. Inside that golf ball, there's this Spaceship Earth ride, and that was the first time the concept of video conferencing was ever introduced, and it just seems so futuristic, so far in the future. And now we have that technology available to us at our fingertips. We often take it for granted, but now we use it in medicine, which to me seems so exciting. Is this the future? Star Wars, will we be having 3D holograms communicating with our patients? So back to business. So for teleretinal imaging, we're all very well aware that it's an effective method for screening and monitoring in diabetic retinopathy in primary care visits, just like Ted referred to earlier. We also know that it plays a really valuable role in screening for retinopathy of prematurity in internationally underserved areas. So how do we take that teleretinal imaging and expand it into the telehealth, this teleophthalmology sphere, specifically for monitoring and treating eye disease, and also to improve compliance and reduce the overall burden of vision loss? So the COVID-19 crisis really prompted us to think fast, come up with some innovative solutions to provide care. But it also exposed a lot of holes, areas where we really need to improve our model to make it sustainable and scalable. So unfortunately, everybody knows that the pandemic was devastating to the entire world. Here in the United States last year, there was a shelter-in-place mandate in 42 states by April. Most hospitals, healthcare institutions mandated that only urgent or semi-urgent cases could be seen in clinic and go to the operating room. And actually, more than any other subspecialty, in-person eye visits dropped more than any other. Policy changes did allow clinicians to bill at a telehealth at the same level as in-person, as you can see on the chart. So each one of these factors really contributed to a rapid expansion of telehealth. Before COVID, it was estimated that less than 25% of eye care providers did any kind of telephone or video conferencing. So looking at the literature, we do know that there is overall a favorable response to telemedicine. Patients report high satisfaction, especially when there's easy-to-use platforms. It's inexpensive for them. They don't have to spend as much time commuting to the office, in the office, and most of them really like the one-on-one communication through the phone, for example. They felt like they were locked in with their provider and there were no distractions. Others felt that because they were doing this telehealth that there may be medical errors, meaning because they're not having a full physical exam. Others didn't like the lack of body language. Some of them didn't feel like they could ask questions. They felt less involved in their care. Until now, we had limited data looking at patient response in ophthalmology. So this study was done at Kellogg Eye Center at the University of Michigan, evaluating the safety of triaging eye care and the patient experience. They looked at 1,700 patients who either underwent an in-person, video, telephone conference call, or they deferred their clinic visit to later time. They found that their triaging system was safe and effective. Only 1.5% of their visits required an in-person visit within a day, and less than 3% within a week. Compared to all the other subspecialists, surprise, surprise, retina providers were more likely to have an in-person visit. There was definitely a value in the face-to-face interaction, meaning patients were much more satisfied if they actually saw their clinician in person or had a video conference call with them compared to doing a telephone visit. Their greatest concern, however, was the lack of ancillary testing, and this has been alluded to by every panelist today, that we really care about retinal imaging, and it's really important in helping us make our diagnosis and treatment. So how can we combine doing telehealth with imaging and come up with a hybrid model? So we're going to talk about that now. So many of you are familiar with all of these platforms, FaceTime, Google Duo, Zoom, Doximity, Microsoft Teams. I just put some of the more common ones here. No matter what platform you use, the ease of use is key for the clinician, the clinical team, and most importantly, the patient. Being able to send a patient a URL that they can just click on, either from their text message or from their email, and join the conference is so much easier than the patient having to download an app, create a username, password, and all that stuff. You have to remember, the population we deal with is a little more technologically challenged, and I'll get to that in a second. When we talk about cybersecurity, so there's a lot of hacking going on in electronic record systems, so it's really important to try to find a system with multiplayer security, with encryption. Also have to consider the cost that comes with that. And then integrating the telemedicine with EHR. And then one thing that we found really helpful was being able to share your screen or collaborate. So you can see on the screen here, the doctor is sharing the OCT image with the patient and being able to point out directly what the pathology is. So let's talk a little bit about the hybrid models. I live in Florida, in Orlando area, and we have over 1,000 people moving to our state per day. And many of the snowbirds that were supposed to come back and see all of you guys stayed in Florida, and some of them became Floridians permanently. So we have a huge population boom, which is a good thing, but also was created kind of an issue during COVID. So we had to come up with a system that was safe and effective to help take care of patients, but also maintain social distancing and all the COVID requirements. So the first model we created was scheduling 4 patients per hour. We had one receptionist who would check the patient in and check them out, and one technician who would do the workup, check their vision, pressure, and then do undilated OCT, fundus photo. The patient would check out, and then the doctor would call the patient at a later time through one of the video conferencing platforms and review the visit with them. This overall seemed like it would work really well, but we did run into issues with the doctor calling the patient back. One, sometimes they didn't answer, they were stuck in the waiting room, you would see their face, but they couldn't figure out how to unmute themselves. There were a lot of issues like that, and it became very inefficient where we'd be waiting like 15, 20 minutes in between each call. So we modified it a little bit. So version 2, we had one receptionist again, one technician would actually do the vision and pressure, then they would go on to the second technician who would do the OCT and the optos photos, undilated, and then a third technician would be in the room with the patient, and the physician is actually on the tablet or screen right here. So the patient would actually complete their entire visit before they left the office. The main goal of doing this was it really decreased the number of patients that came into our office at any given time. We never had more than one person in the waiting room. It was very convenient for patients. They liked having fewer people in the office, and it was really convenient for the clinician. So if we were at home or if we were in another office or if we just finished in the operating room, it was really easy to see 15, 20 patients. Again, not for every patient, I'll get to that in a second. And even once we started picking up on getting busier in our clinics, we would still take some of our routine clinic visits, for example, an epiretinal membrane follow-up 6 months, and try to decrease our overall volume so we wouldn't have that many people in the office at any given time. So like I referred to, it was not ideal for all patients. We would not schedule any post-ops, any patients that may need treatment, any patients that would definitely need an anterior slit lamp exam like a uveitis patient. The other thing is we have a few trained photographers, especially for our studies, but most of our technicians, they're still in training for a lot of stuff, and we don't have dilated eyes. So we can often get even more artifacts with that. And so being able to have the software, so in our case we use the Opto software and Heidelberg software, we're able to open those on our screen wherever we are and actually scroll through all the images and then be able to share the screen and show the patient what's going on. We found that to be helpful. So there are peer-reviewed data that have shown that hybrid models are effective in terms of shortening time from referral to treatment for those who needed it, and safe, meaning it allowed more efficient resource allocation. So let's talk about the future. Where are we headed? And we've all discussed that a lot of what we do, we rely on imaging and we rely on ancillary testing. So one important thing could be home monitoring devices that may help us in terms of assessing how our patients are doing and how quickly they need to be seen. One device that's on the horizon that seems pretty promising is home OCT monitoring. So after a 2-minute tutorial, patients are able to take an OCT of their eye using this device. There's software involved that then does an automated analysis that's sent to the physician to interpret and document it. It's currently going through an innovation pilot program, and the American Medical Association is actually coming up with billing codes that can be used for a physician to interpret this. This, some of you may be aware of, the 4C home monitoring device. A lot of my patients actually really like this. They think it's more than just looking at the Amsler grid. It's an at-home device designed specifically to look at any early detection of wet AMD. It's FDA cleared and covered by most private insurances and Medicare. The Ally app is a Swiss smartphone app that looks at monitoring of an existing retinal disease's progression, looking at central and paracentral metamorphopsia. Home Vision Monitor is currently being piloted at Moorfields. I tried to open it, but you actually need a prescription, so that's why there's only a picture of the device on it. I tried them all out to see how they work. So what's down the pipeline? So we have already heard about artificial intelligence, and that's going to play a huge role in terms of any kind of retinal imaging that we do, but especially in telehealth. When and how are we going to get smartphone fundus photography at home? I think that could be a huge game changer for us. Some people, I've heard talks about people referring to kiosks in rural areas, whether it's at a pharmacy, whether it's at a family practice place, so similar to the concept of teleretinal imaging, but where you could actually have an actual physician talking to you through a camera. Is telemedicine here to stay? Will patients still want to continue this, or is it just going to be strictly for emergencies? I think a lot of it has to do with the policy and reimbursement as well. So just some questions to ask. Maybe we can even discuss some of this on the panel. But just want to say thank you again for having me.
Thanks, Jaya. Justice Sailors, take us home, bro.
Thanks, Neil. So I'm actually, these are my financial disclosures. I'm going to actually start at the end. So when we look at COVID and telehealth, we heard a lot about some very exciting technologies, and Jaya, I love seeing how your practice really went about very methodically how to do this. I guess starting with you, did you find, was there a difference in the way different physicians utilize this? Did everybody use it? Did you implement it across your offices?
It's a good question. I would say in the local region, I would say 4 out of the 6 of us used it. some more than others. This actually, so I was actually on maternity leave in July of 2020. And toward the end of my maternity leave, I started using it just to see some of my patients. So my clinic, when I returned, wasn't super busy. So that's when I actually started using it on my maternity leave. But then later on, we did a couple Saturday morning clinics where the physician would be at home, but then we would have technicians go in just to help decrease or just decompensate our clinic so it wouldn't be so crowded. Yeah. But yeah, we found that it was effective, it was helpful.
I mean, I can see the real appeal of that hybrid of having a technician sitting with the patient and making that happen. I mean, for me, that was one of the biggest barriers of using the virtual video approach for it. Glenn, what about at Duke? Did you guys implement any sort of virtual aspect of care, and how did you use it, if at all, in your practice?
I actually did not use it. There was a very short window for us between having patients tamp down to emergencies to then building it back up again. So that window, at least for us, was very short. But several people did make use of it. We did not integrate imaging, which would have been a much better thing to be able to do. I did do a few calls, and the patients really like it because they get the one-on-one. I didn't find it very efficient, though, because it's
hard to get them off the phone.
It's hard to get them off the phone.
I agree.
You know, and that was my key struggle. I mean, even at your 6/8's getting better, 4 patients an hour doesn't cut it for the volume that we're normally seeing.
Right.
So Risha, you did a lot of work on this at Cole and how we can more efficiently integrate it, and showed the huge number increase of our clinicians who were using it. Can you tell us a little bit about what you saw of the curve change over time, and where is it now in terms of utilization at the clinic?
We actually have a paper that we published on our experience with it, which was really quite interesting. So first and foremost, it was optometrists and our plastic surgeons that were using it far more than everyone else was. They had we actually did an experience survey and looked at patient experience compared it to in-person visits. They had equivalent experiences with regards to their ability and Press Ganey scoring to look at their satisfaction with the visit. So they were very happy with it. That being said, obviously, we had to migrate models. And so in retina and in glaucoma, we had a hybrid model, like Jaya was nicely pointing out, where the patient came in, they had vision, pressure, and typically a visual field or an OCT, and then they would leave, and then they would have some follow-up. In glaucoma, that's easy because all you're doing is adjusting meds. In retina, it's not so easy because you have to give them a bunch of injections, so it wasn't that easy. And I think the big thing that we changed was our overall flow pattern in the clinic. And I'll have to credit Peter Kaiser, who for years told me we need to put the OCT next to the lanes. And I was dead against it because there just was a lot to do for the patient. We realized the patients were, requiring chair time was significant. You had to open their eyes a lot of times with 2 people. And I just didn't think it was feasible. And actually, it's worked really well. We've had a great throughput by putting the OCT right in the lane. The only problem with it is that OCTA is still a problem with that because of you have to have truly a dark room. You can't get an OCTA in a situation where you're in the middle of a lane and doing an OCT. So the OCTA falls apart, but everything else worked great.
Yeah, and it's interesting in all of this because obviously our primary goal is around patient care and quality, but there obviously is a business component to this of sustainability and how it works for the clinician. One of the things that we had done in my clinic was we had essentially diagnostic fast tracks where these were patients who were stable. They didn't want to come in so frequently. They'd just come in and I'd tell them, you're not going to hear from me as long as things are fine. And we wouldn't even do any follow-up, but all you're billing for is the OCT. And so we started ramping that up more in COVID, but the challenge is that it just, being able to do the full visit when the reimbursement was the way that it was. David, what about at UCLA? How did you guys handle this?
Yeah, I mean, some of us are using telemedicine. I think that's certainly an important way to adjust during the pandemic and also to adjust in general with the high volume. Myself, I've really not altered any of my patterns. I need to see especially the ones who need their injections, the AMD patients. I haven't really changed since March 1st, 2020. Yeah. I've been doing all my AMD injections the same way I have right from the start.
It's funny you say that. I remember on our early retina service calls, we were talking about we're never going to see 70 patients again. This is going to change everything forever. And it feels like we're seeing more than ever before, you know, in our current practices. So, you know, that I guess is, you know, when I look at this, you know, Peter, for you, as you look at changes you made, we had a lot of debates on our service of, is the exam the important part? Is the OCT the important part? How much do you have a patient traveling throughout your clinics? What were the things you changed early on, if anything, and have any of those things endured for you?
You know, it was difficult. We wanted to make the patients feel safe, especially early on. We knew the AMD patients in particular, the wet AMD patients, we needed to get in, get their injections. The clinical trial patients were others that were high priority for us. So what some of the things, as you know, that we did was, first of all, space out our exam lanes, don't move the patient. Usually you'd work them up in one place, you'd go to an OCT somewhere else, you'd have them sit in like 3 or 4 different waiting rooms, and then you see them in a different room. And we completely changed that during the pandemic. Now we're going slightly back at this point because our numbers are back up around 60, 70, so we can't really leave the patient in a room and have everybody else rotate through it. We're starting to move back, but we clean a lot. Everybody's working harder. It's a much harder visit. I'm much more tired after a 60 patient day than I used to be after 80. I mean, it's just kind of crazy.
Well, and it's funny for me, you know, one of the changes that I assume many places implemented were the number of visitors that could come in with patients. Yeah. And initially, I thought that was amazing because there was less talking that needed to happen. You just talked to the patient and got them out. And now as we start to allow the visitors back in, and it's this interesting push-pull between what the Office of Patient Experience needs, and obviously this is valuable for the patient experience, but then what is the clinician side of us trying to be as keeping our, you know, waiting rooms empty and all of that. So I'm curious on the panel here, before the pandemic, how many people wore masks for their injections? Yeah. Wow. And there's obviously, you know, data that's out there around the improved safety potential of that related to endophthalmitis, you know, data that's been shown from different groups. And now all of us are doing it, you know, I assume pretty much across the board. And now our patients are wearing masks too. I'm curious, you know, Kat, for you, if let's say that in 8 months we get rid of the mask, you know, mandate, and we're no longer wearing it for COVID reasons, are you going to still wear it for your injections?
Yeah. It's interesting. I I was not somebody who wore masks for injections before, but there's lots of benefits to wearing masks now. I used to be, you know, when we would do injections, I'd feel very conscientious if I was talking, the patient was talking, and that kind of sometimes makes things difficult. And so it's nice having a little bit more trust in that process. And I also feel like I just get sick a lot less than I used to. And I think now I'm just keenly aware of when you're doing a slit-leg exam, how close you are to people, you know.
Yeah, I definitely like the splash, you know, shields that we have now.
Yes.
Glenn.
Yeah, I would agree with Kat. One of the things I used to do when we didn't have masks, and whether it was a periocular steroid injection, intravitreal steroid injection, I would talk to the patient while I was doing it almost as a hypnosis type technique, and then I stopped doing that completely when everybody started talking about you shouldn't be talking during the exam, and now I'm able to do that more. The other thing about the patient with the mask, there are people, you're probably familiar with studies that have been done about particles that go around masks, and my big complaint with those studies is that they didn't actually tape the top of the patient's mask or were using adhesive masks. So when I have, both in the operating room and in the clinic for the injections, I make sure that the patient's mask is taped, because if you look at the studies, the bacteria go right up into their eye because it's funneled from the top of the mask. And it's also in the clinic, I do the same thing as a good way to avoid the patients taking their masks off, although they found ways to lift it from the bottom.
You know, and that's something we've implemented as well, is, you know, taping the top. Do you guys leave the mask on during surgery for patients?
Yeah, we use the same kind of mask I have now. It's a Precept mask that has adhesive underneath it, and so they cut off the tails on it and then stick it down, and so it doesn't cause bacteria going towards the eyes.
Yeah. So, Sunil, obviously, with your practice, you have patients that are unique in terms of the uveitis side that may be coming in for fairly frequent visits. What adjustments did you make in terms of clinic flow, how you handled it? Were you able to change anything just based on the sheer volume and demand?
The last 18 months have sucked. I mean, I think that it's been challenging. A lot of my patients are immune suppressed. lot longer conversations. You know, we tried our best to do this virtually. I'm still adjusting, and we did things like, you know, come in, get an image, and I'll talk to you on the phone. I found very similar to Glenn, I couldn't get off the phone then, you know, because these are complicated conversations and they took longer. Yeah, I'm still trying to figure out how I should adjust. I'm busier now than I've ever been, and most of the patients who didn't come back are now flaring and have really challengingly difficult diseases to control from an inflammatory perspective. And, you know, there is now, just with the whole immune suppressing and more data on like the risk of COVID with it, it's, these are harder patients to take care of. So yeah, I'm still trying to figure out how I should remodel it, but I think my numbers are higher now than they have been ever, and my complicated patients have gone up. So that's just been my experience. This has not been an easy 18 months.
Yeah, I mean, my experience, I felt like, you know, we went back up to our normal schedules generally in September, but I feel like once the vaccine hit, we exploded and are busier than we've been. You know, Jaya, you mentioned the population change, which is a really interesting dynamic. And I've seen those patients who for 18 months, they were stuck down in Florida and decided they'd come back for one visit. How have you guys handled that? Are you recruiting? You know, have you guys?
We hired.
Does anybody need a job?
Since I joined, this is my 4th year, we've hired 3 new doctors. We're growing because there's such a need, and our clinic volumes haven't gone down, they've gone up.
Yeah. So I guess last couple of questions here, and then we'll wrap things up. You know, it's funny. I'm sure everyone's experienced some of the challenges in the labor shortage that's out there in the world. My wife pointed out to me that every Starbucks in Cleveland closes like at some early time, and they're no longer open, even like on Saturday mornings, which is, you know, kind of nuts when you think about the challenges that we're facing. Have you, Glenn at Duke, you know, from a labor standpoint for your support teams, has that been a challenge? How have you guys handled that?
It has been a challenge. I mean, we're down technicians, and it's been very difficult to get them back. And I've had several conversations, because it's not obviously just a problem at Duke, it's nationwide or worldwide. And the question is, where are all these people going? And some of them are retiring early, some of them are going to Florida and deciding to live there, and some are working at home and getting different types of jobs where they can work at home. But it is a definite problem, both in operating room staff and technical staff.
Well, and it doesn't seem like there's an easy out here. You know, it's endless. David, what about in LA? I assume similar challenges there from?
I think so. I think there's just a general, people have kind of gotten a taste of what it's like not to have to work and to be able to stay home and work. It's more an issue, I think, with my wife and her. She has a industrial supply, manufacturing and distributing business, and it can be challenging to get patients back into the workforce. There have been days too where technicians don't show up, or it's tough to get them back. I can think of a couple of technicians that I haven't seen in several months during the pandemic. So it's definitely a challenge. We'll have to see how the workforce adjusts going forward.
Well, and even on the financial side, the labor market, you know, they're saying minimum wage is irrelevant now because people are getting paid so high now. You know, nurses are leaving to go do PRN, you know, jobs getting paid insane amounts of money. Sunil.
I was to say, you know, the stress of seeing patients and, you know, what's been going on. You know, we look at all these telemedicine models. The doctor is somewhere else. It's our technicians who are front-facing.
Yes.
And I think we have to be very aware of that. And this is something that worries me about, like, you know, this, like, essentially this medical class. And we're seeing it in nursing because the nursing shortage is getting worse. A lot of people just leaving the workforce because they feel like they are the ones bearing the brunt of this. And I think our technicians are no different in this. And I think, you know, we see 80 patients or 70 patients, maybe it's 5 minutes a patient or 10 minutes a patient, and our technicians are spending 20 minutes with somebody, and I think that's something that they're all deciding there's a better job for them in this whole thing. So we have to make adjustments for our technicians as well to really kind of make it easier for them.
I mean, I think that's really important. You know, when we look at engagement, you know, the risk of a true crisis here as people leave, the people who are hit the most are those former coworkers, those other technicians who are having to hold up that extra amount of work burden. So,
Yeah, it'll be interesting too how vaccine mandates, as they start to go more into effect, will
Yes.
alter things as well.
for sure, I was gonna, that was a great, question and topic as well, Cap, because it's something that we're facing, certainly at the Cleveland Clinic, is how is that, as that rolls out, are things gonna be looked at? So I think we'll wrap things up here. I wanna thank our panelists, as it's been a fantastic meeting, and as well as our sponsors for making this possible, to Jara and Alana for all of the work that you guys have done to make this meeting work in the way that it's gone so seamlessly. To our in-person as well as virtual audience, thank you for joining us.